Well, we'll carry on anyway. So, good morning to everybody again. I guess it wouldn't be appropriate, really, not at least to make some mention about Ukraine and the whole Russian thing. And I just wanted, clearly there's nothing that any of us in this room can do about that other than perhaps donate and support. You may well have, some of you may have staff that either have family members in Ukraine or maybe even staff who are Ukrainian themselves. So I just wanted to at least make reference to that at the beginning of the meeting because we might be in a tight spot here in the room, but the tight spot that people are in there is just unbelievable, isn't it? So I just wanted to make reference to that. So moving on in relation to this morning. So those of you who don't know me, some of you might not have met me previously. I'm David Smallacombe. I'm the Chief Executive of Care and Support West. And this is almost the first real event, real people event we've had in a very, very long time. We did have a real event last year with our awards. And you'll see when you get your coffee and tea at the back there, there's a big poster about the awards. If you haven't nominated, so I'm always ready to make a plug, if you haven't nominated your staff, some of you will have, I know, but if you haven't, then the closing date for nominations is March the 18th, so it's not very far away. So please, when you get back to the ranch, do have a look at the website, all the W's, careandsupportwest.com, and you'll see on the top line awards, and you can then drop down on the boxes and make nominations. We really encourage you to do that. This time of all times, really, there couldn't be a better time, I guess, to be nominating people for the work they've been doing in and around your care settings. So I really encourage you to do that. Now today, I also want to welcome 6 speakers, 3 of whom are real with us and 3 of whom are not. Our first speaker today is Chris Naylor from the King's Fund, and we'll get going with that in a moment. Ros is here, Ros Cox, hand in the air there, and Jeff is here as well. So that's two real people. Oona Goldsworthy from Bristol Care would have been here, but sadly she came down with COVID at the weekend, so she isn't able to be with us today, but she'll be coming in remotely. And Deborah Al-Sayed is also going to be remote with us today. So, and Hugh is here. Where is Hugh? There he is. He's the 3rd real person here today. So that's really good to see people here. So we're here to focus on integrating care. I just wanted to say just a few things, not very long about that, but there's something about, this is a different shift, a new shift, and it's one that has been spoken about for a dog's age, as we know. Certainly my first memory of this was, I think, the 1989 Community Care Act. But it's been a long while coming around, but here we are still. And it feels to me, though, that we are closer to having an integrated care system, which is really great. So, we're talking now about collaboration, not competition. We're talking about joint ownership, not single silos, valuing all professions. That's really, really central and important to all of this integrated system. Equality of access between and across health and social care. Not easy to do, and we've struggled with that over time, but now is a real time to do that. So supporting and helping each other grow. I'm thinking teaming up to influence government. Now, everybody sitting in this room knows that there are a range of ways in which social care is in dire straits and influencing government, challenging government. I know also that, if you like, local authorities are between a rock and a hard place, aren't they? So, you have local authorities who understand and are clear that the provision of adult social care is in a really difficult position, not only in terms of staffing, but also funding. But then they themselves are also in a tricky position. And yet again, come the new financial year, central government will be removing funding from them. I'm sure Hugh will talk a bit about that. So it's something about challenging government, but also something about covering each other's back. Something, you know, we need to get to a place where health and social care are doing that rather than putting knives in each other's backs, to be frank. So we need to be doing those kinds of things. So unless we should forget the central part of all of that, this is about people care. It's about the day-to-day delivery of people care to vulnerable people, vulnerable citizens in all the areas in which you work. That's what this whole thing is focused around. It's what we need to focus ourselves on. So today we're going to talk national, we're going to talk local, and we're going to talk systems, particularly in relation to commissioning and providing. So what's this new way of working? When is it going to happen? How soon is it going to happen? And what's it going to look like? So those are the things we're talking about today. I'm going to stop there. During the day, there will be little Q&A bits after each speaker. So by all means, note your questions down. If you're virtual, then pop them in the chat and we'll pick them up and be able to then ask the speakers about those. So I'm going to virtually welcome in a moment Chris Naylor from the King's Fund. Are you there, Chris?
I am here. Yeah. Hi, David.
Oh, I can hear him.
I can't start my video. It's not giving me permission to start my video at the moment.
Okay, let's ask the AV team about that. Two seconds, Chris, they say. The challenges of new life.
Can you hear me loud and clear though, David?
The other thing I guess we can do, Chris, is we can put your slides up and you can talk to them because you'll have copies of them, obviously.
Yeah, we could do that. I mean, I could just try sharing my screen. At the moment, I'm just trying to turn my video on so you can see me. But it's saying that the host has stopped my video. But shall I try putting my slides up? Oh no, I can't. It's saying that screen sharing is disabled as well. So at the moment, I can't do either of those things. The perils of hybrid working. We're all kind of learning as we go with these things, aren't we?
It's on screen, Chris. So your first slide, health and care reforms, understanding, etc., your name and the King's Fund is on the screen. So can I leave it to you to continue on from there, Chris?
You certainly can, David. Yeah, that's absolutely fine. And I'll kind of let you know or let someone know when to flip onto the next slide. So morning, everyone. Pleasure to join you today. Join you remotely, but apologies, can't be with you in the room. I was really kind of keen to join this event when David invited me because I think it's such an important issue for us all to be getting our heads around. So the brief I've been given is to talk a bit about the kind of national picture, the health and care bill that's going through Parliament at the moment, what the idea of integrated care systems are, where they come from, what some of the challenges might be as we're kind of putting this new vision into practice. So that's what I'm going to talk about, and I'm sure some of it will be familiar to many of you because you're kind of living and breathing these changes at the moment. But hopefully it will kind of be a useful start for the day, just to kind of recap some of these principles. So if we go on to the next slide, I guess the first question to ask whenever we go about reforming health and care services, which the government likes to do every few years, as we know, is why? Why are we bringing about these changes? Well, fundamentally, the answer to that question is what we all know about the changing health needs in the population. So the job of a healthcare system has changed hugely over the decades. If it used to be more about curing people from a single episode of acute illness, it's now much more about supporting people with long-term conditions, often multiple long-term conditions over a period of time, and often people with significant social needs and other kind of complexity in their lives as well. So all of that means that we need to get much better at integrating services, coordinating care and support around the person. The problem is the way we commission services and the way the money flows, there's often been a barrier to that, hasn't it? So the development of integrated care systems is intended to be an opportunity to change that and to remove some of the barriers to collaboration that exist between different parts of the system. If we go on to the next slide, in some ways, I think this is a really kind of this is a really profound shift. We can all feel a bit jaded when the next set of reforms comes along and think, well, is this just going to be a new 3-letter acronym and nothing significant changes? I think potentially here there is something really significant going on. What we've seen in policy terms over the last few decades is a kind of long-standing tug of war between different ideas about how you improve services. Do you do it through competition, so getting different bits of the service to kind of compete against each other, and by doing so driving up standards for everyone, or do you do it through collaboration, working together across organizations, across silos? And I think it's fair to say that the kind of improving services through market-based mechanisms and competition has been one of the kind of dominant ideas over the last 20 years or so. And that this health and care bill that's being discussed in Parliament at the moment represents a turning point away from that. So I sometimes see the last Health and Social Care Act in 2012 as being the high watermark in terms of trying to use market-based mechanisms to drive up standards. And actually what we've seen the system doing since then, certainly from the 5-year forward view onwards and then the long-term plan, is trying to kind of row back from that and put a focus on working together in place-based systems of care. So from 2014, really, we've seen the NHS and care organisations trying to do their best to live within a legal framework that's really been increasingly out of kilter with how the system's actually being run in practice. And what happened a year or two ago is that NHS England effectively said to the government, we think we've gone as far as we can with this. We need legislative change now to bring the system more in line with practice. So the health and care bill is in large part a response to what NHS England and other organisations asked for. I say in large part because there are also things in the legislation that come from the government that they've inserted, and that, yeah. So, but to an extent, this was a response to what the NHS has asked for. If we go on to the next slide, the kind of central construct in these reforms is the integrated care system, and how NHS England have always described integrated care systems is as about bringing together the kinds of organisations you can see on this slide to take on collective responsibility for reaching a shared view of local needs, agreeing a direction of travel for health and care services in the local area, and then sort of kind of supporting the service changes that are needed to deliver that aspiration. I put the emphasis on this idea of collective responsibility because really where the idea of ICSs comes from is the idea that, if you're running the Salford Royal Hospital up in Manchester, and one of your neighbouring NHS trusts is having problems, then actually that's not just their problem, that's your problem as well. And the system needs to respond collectively to that problem. By the same sort of logic, if you're an NHS acute trust provider, and your social care providers in your local area are facing real challenges, that's not just a social care problem, it's a system problem, and it's a collective problem that needs a collective response. So that's very much the kind of ethos behind these reforms. If we go on to the next slide, you probably all know that, apologies, thank you. The ICSs aren't just being created out of nowhere. They had their roots in the sustainability and transformation plans that were created from 2015 onwards. And then what happened in the years since 2015 is that these sustainability and transformation partnerships, which saw local government and NHS and other partners kind of coming together to plan together in a longer term way than they had done previously. From about 2017 onwards, NHS England started talking about ICSs essentially as the sort of next step beyond STPs. So the idea was that, if you can demonstrate that your partnership is sufficiently ready and at a level of maturity, then you sort of graduate and become an ICS, and that means you get a bit more autonomy and a bit more responsibility as well. And then from 2017 onwards, more areas of the country sort of made that step of becoming an ICS. By April of last year, all of England was covered by ICSs. Now, throughout that period of time, ICSs were just informal partnerships. They were organisations coming together, people doing it on top of other jobs, no formal powers. Everything rests on soft power, on building consensus, taking people with you. And on one argument, that's been the very strength of ICSs so far, because arguably, if you bring change through building that local consensus, it's more likely to stick. But other people have argued that actually you can only go so far with a voluntary partnership, and that sooner or later you need something with more teeth, where there's a legal obligation to work together. And that argument has won out, and that's effectively what is now happening through the Health and Care Bill. So if we go on to the next slide, the big change that will happen in July is that ICSs become statutory organisations for the first time, with legal accountability for NHS budgets and a raft of other responsibilities as well. And that creates a bit of a dilemma, because from 2015 onwards, the people that have been running STPs and then ICSs have been absolutely at pains to position them as being equal partnerships between the NHS and local government and other partners. And as soon as you turn something into a statutory NHS body, the risk is that that spirit of equal partnership is changed fundamentally. So the proposed response to that in the Health and Care Bill is that every ICS will have two bodies leading it. There's the Integrated Care Partnership and the Integrated Care Board. So the Integrated Care Partnership is where we're trying to keep alive that kind of spirit of equal partnership that people have been trying to build over the last few years. It will have quite broad membership from local government, from voluntary sector organisations and beyond, including social care providers, I would expect. And the main responsibility of the Integrated Care Partnership is to develop a strategy drawing on local health and wellbeing board strategies. And then the Integrated Care Board is in some ways, it's the successor to the CCG. It's where the NHS money will sit locally, and that will be the bit that's kind of legally responsible for how NHS resources are used and what outcomes are achieved for local people. So one of the kind of key things about how these reforms are put into practice is what is the relationship going to look like in each area between this Integrated Care Partnership, in the integrated care board. And where's power going to sit? Because certainly the kind of the statutory responsibility and the resources sit with the integrated care board. But if these reforms are going to be successful, the integrated care partnership has to be an equal partner in this. It can't just be a talking shop. So that's one of the things that needs to be figured out in every area, and I suspect it's going to the end result is going to look quite different in different parts of the country. Just a word on the terminology here, because one of the unfortunate things is, so the Health and Care Bill invented this term integrated care partnership, and the acronym for that is ICP. Unfortunately, ICP in many parts of the country was already being used to describe the partnerships that are being built at a more local level, at place level, within ICSs. So just a note on that, that if you're talking to someone at the moment about ICPs, make sure you're both clear about which ICP you're talking about, because I've started to see people getting kind of crossed wires when they're actually talking about different things. So if we go on to the next slide, a word more on that kind of more local place level that sits beneath ICSs, because the idea with these reforms is that although the legislation is mainly about ICSs, and that's where the statutory responsibilities sit, it can't just be about that level, because actually much of the work of bringing together health and social care services needs to happen at a much more local level. So NHS England talk about system, place and neighbourhood. At system level, you've got the ICS, but at place level, you also have to have arrangements for partnership working. So we call them place-based partnerships rather than calling them ICPs, just to avoid the sort of unfortunate confusion with integrated care partnerships at system level. But the idea is that the system tier focuses on the strategic planning, the monitoring, trying to remove some of the kind of blockers to integration. But it's at place level and at neighbourhood level where a lot of the service change and the real kind of work of integration needs to happen. If we go on to the next slide, I just want to kind of emphasise this point about place again, because certainly our view at the King's Fund is that the place-based partnerships really need to be seen as the foundation of integrated care systems. So in effect, the ICS is built up out of what happens at place level, and it is not supposed to be a top-down hierarchy where place-based partnerships report into ICSs. That the NHS England has been quite clear about that. So if you look at the middle document here, Thriving Places, that's the guidance that came out from the LGA and NHS England about place-based working. And that is very much about the principle of subsidiarity, not seeing this as being a kind of top-down hierarchy between system and place. But it still remains that the statutory responsibilities are going to be sitting at system level. So there is a danger of power being sucked up to that level through these reforms. And I think that, in a nutshell, is why the government took the step in the last few weeks of publishing the white paper on the right of the screen, the integration white paper, joining up care for people, places and populations. And really the government's intention with that white paper is to kind of put a bit more robustness around what happens at place level, because they were hearing from NHS England and others that it's not all about ICSs. Place-based working is really important as well. But then lots of MPs were saying, but hang on, the legislation is all about accountability. You know, if you're saying it, place is really important, but we don't have any kind of legal accountability for place in the Health and Care Bill, we're nervous about that. So the white paper is a response to that, and as you probably know, the main things in it are about saying that at place level, at the more local level, every area is expected to set up some kind of formal governance arrangements for partnership working at place level. There has to be a single leader who's accountable for bringing things together at that level. So there's an interesting dynamic I think that this creates between the leaders who are going to be at ICS level and the leaders at place level. And the white paper in some ways gives a bit of a boost to the people who are working at place level. If we go on to the next slide, I wanted to kind of start wrapping up now and just kind of pose the question, will any of this lead to a different outcome? Because we've been before. Chris Ham used to be the chief executive of the King's Funds. In recent years, one of the things he's been doing is he's been an independent chair of one of the ICSs in the West Midlands. And he said that his vision is that ICSs should look and feel different to any organisation we've had before or in the NHS. So what could help ICSs become fundamentally different from their predecessors, from CCGs or any of the others? Well, firstly, I think they will be different if we get this spirit of equal partnership between NHS, local government, voluntary sector, and I'd add kind of social care providers to that list. If we get that spirit of equal partnership and collective responsibility right, that means that ICSs could be fundamentally different from just being the latest NHS commissioning organisation. I think it's also equally important that we get this principle of subsidiarity to place level right, and that we develop more nuanced models of accountability. So we still need accountability to the national level, to central government, because the NHS at least is it's a kind of taxpayer funded system. It needs to be accountable to national government. But I think we need to balance that with a sense of collective accountability between the different partners involved in these organisations. And the last thing that I would add to my list of what could make it different this time round, I hear a lot of ICS leaders acknowledging that we need to get much better at using insights from local people, from service users, clients, patients, families. I think if we do that right, that could be really transformative. So my last slide is about the opportunities and risks in these reforms. We do think at the King's Fund that some of these reforms could be helpful in as much as they remove some of the barriers to collaboration that have existed over the last few years. But the legislation is just an enabler. You know, fundamentally, it's not the legislative changes that will determine how this plays out. It's how people kind of use these new responsibilities, powers within your local systems, and how local leaders implement these reforms is going to be the big thing that determines whether they'll be effective or not. I talk to ICS leaders who, I think they sincerely want it to be different this time. They want to build different sort of new partnership-based relationships with local partners. They want to be working differently with local communities. They want to shift resources upstream and give greater priority to prevention. But we all know that the kind of the national to-do list for the NHS in the wake of the pandemic is going to be very very long and will be kind of managed very assertively by central bodies. So the question is, will local leaders have the headspace to put in place this different way of working at the same time as handling the kind of recovery from the pandemic and trying to recover, work through the backlog for elective care and all of the other things that are sort of very much on people's minds at the moment. So I'm gonna leave it at that and take down the slides. I'm aware I'm sort of run slightly over time. So David, over to you. And if there's time for any questions, I'm very happy to take some questions. But if we need to move on to the next presentation, and obviously I will let you make a call on that.
Thank you very much, Chris. Really useful presentation. We started a bit behind time, so if we continue to be a bit behind time, that's fine by us at this end. I'm just looking around the room to see if anybody has any particular questions that they want to place back to you. Don't see any hands being raised, but let me have another look. No. Are there's some perhaps on the chat, are there? Oh, you're getting compliments, Chris, on your slides.
Oh, that's always lovely on a Wednesday morning. I'm scrolling through. I can't immediately see any questions other than the question about will the slides be available, which they certainly will be.
Yes, they will be. I have a question though. From your national position, I'm interested in the inclusion or otherwise of social care providers. Oh, there you are. We can see you across the national piece, because it's a continuing challenge at this end, shall we say? And I know that Jeff and Hugh and others will be saying things about that probably later on through the presentations. But what's your thinking, and what's the position you're seeing nationally in relation to that?
So you won't be surprised to hear that it's, I think what you're experiencing in your part of the country is part of a national, wider national problem. I think, and it's not just about social care providers. So I think there's a real issue that needs to be worked through at the moment about representation on these new bodies and who's included where in the new system. So I think it's really important that local government has a sort of powerful voice within ICSs. I think it's really important that voluntary sector organisations are seen as kind of genuine partners. And similarly, I think social care providers absolutely need to be heard, not least because it's often the kind of provider organisations working locally that have are most in touch with what people need and want in the local area. So the role of social care providers as a kind of conduit for the voice of clients and service users, I think is really important. We're doing a piece of work for NHS England that we've just started at the King's Fund that's going to be looking at that. So my colleague Simon Bottery is leading a piece of work over the next kind of 4 months or so, which is going to be talking to social care providers and talking to people in different parts of the country, seeing what different models are emerging for how social care providers could be part of the ICSs and indeed the place-based partnerships that sit beneath them. So hopefully we'll have the opportunity to speak to some of you directly through that piece of work. But what we're trying to do is to kind of identify some models of good practice and some different ways that this could be done. It's certainly on NHS England's radar as an issue because they commissioned us to do this work. So I think the problem has been recognised, and we just need to kind of figure out what the potential solutions to it could be.
I'm really keen if Simon's doing some work on that he gets back in touch with us down here in the west of England, because we've got lots of views about that. There are a couple of questions in the chat though that I can read out if I may. The first one from Bethany Lacey. Will ICSs be working along CCGs or replacing them totally? First bit of the question. And as a private provider of social care services, how would we fit into our local ICS, and how would we be required or invited to be involved at all? So that's a question about the ICS rather than the integrated care partnership bit.
Yes. Okay. And thank you for the question, Bethany, because I wasn't clear on this in my presentation. So what happens, assuming the Health and Care Bill goes through Parliament over the next few weeks, then on the 1st of July, CCGs will cease to exist and their powers will transfer over to the Integrated Care Board, so that bit of the ICS. Now, the legislation is pretty permissive about who needs to be involved in the Integrated Care Board. So there has to be a representative from local government, there has to be a representative from primary care, etc. But there isn't, beyond those kind of general requirements, the the approach the government is taking is to leave it to local areas to decide who should be sitting on the ICB and who should be sitting on the ICS, and what overlap there should be between the two. And I think that's probably the right approach, because if you try and pin everything down in legislation, it can get very prescriptive and it can have all kinds of unintended consequences. I think it is better to leave it to local discretion, but that does mean that in each part of the country, we need to be making sure that providers of social care are kind of sufficiently represented within these new structures.
Okay, thanks very much, Chris. There are one or two more questions, but we are pushed on time right now. So what I'm going to suggest is that we capture those questions and we'll send them to you. Well, you'll see them anyway on your screen. If you could maybe do some email responses to those questions, that would be great.
Very happy
obviously,
to, yeah.
I think you're going to be around towards the end anyway, aren't you? So we could pick some of that up then.
Yes. Okay. I'm very happy to do that, David. Yeah, thank you.
Lovely. Thanks very much. So can I invite Hugh, a real person? Well, not that you weren't real, Chris. What am I saying here? Digging myself into holes big time. Hugh Evans, People Director from Bristol City Council. And I imagine some of those things that Chris has been talking about will have been ringing bells with you, Hugh. And we'll hand over to you. Thank you very much.
Thank you, David, and thanks, Chris. I think I'm more of a surreal person, actually, or at least this situation feels somewhat surreal. I haven't stood behind construction like this and spoken to people for over 2 years. In fact, I've barely been out of the house, so bear with me. I've written quite a lot of this down as well, so I think that might help. Excellent to hear Chris's summary. He's preempted some of the elements of this presentation, but perhaps we'll look at them with a slightly more local focus. I'll take the question that Chris asked as to whether local leaders will have the headspace to do this really quite seriously. I think we have to make that headspace, because we need to do something like this, because the way that we're working at the moment is not terrifically effective, and it's not going to solve the problems that we face as systems following the last couple of years and the preceding 10 years. So for us, for me as a social care leader and overseeing quite a lot of spend in the social care sector, absolutely, certainly we will make the headspace, because this is our agenda. I think the other point I'd like to highlight as well is that a lot of this is up for grabs for us locally. It's up to us to determine how we shape this, what we do with it. And, I know I can speak for Bristol certainly, but North Somerset, South Gloucestershire as well. We've got some very forward-thinking people who are really quite keen to do this at breadth and to do this in a manner that incorporates the range of people that are involved in the healthcare and wellbeing world. Because it's really important to ensure that they're involved. So can we go on to the first slide, please? A lot of the key themes in this agenda aren't really very, I've got monitors. I should have brought my guitar. That would have been much better, wouldn't it? Put my leg up and, no. Right, okay. So a lot of the key themes in this agenda aren't new. NHS and local authorities working together more effectively on a place basis, developing the potential for integration and integrated service delivery approaches, joining up care and care delivery to ensure better coordinated care, greater seamlessness between deliverers so that people get what they need, and that emphasis of things being right first time, every time. They're not new concepts. We've been thinking about these things for years. And so in that regard, this is a very welcome reframing or refreshing of that agenda. There's lots of positivity in the intended outcomes element of it. You can read them for yourselves, but collaborating, sharing resources and data, enabling development, especially as I'll go on to mention later when it comes to building resilient and fair communities that build upon their existing assets, communities that support each other, and communities that are self-sustaining. So can we move on? And Chris has mentioned some of this, so I won't go into huge amounts of detail. We can see here the pathway for the Health and Care Bill as it proceeds towards becoming law. I think it's fair to say that the bill's having a bit of a rough ride through the Houses of Parliament and Lords. There's an awful lot of politics bound up in this work, and the global nature of the scope of the proposals, especially when it comes to considerations and assumptions about the role of the statutory and the market sectors in the delivery of health and care services, it creates a real wariness about the agenda. But it's interesting to note that Chris highlighted that the very market-driven ideas around NHS and statutory provision of the first part of the 2010s have actually flipped a little bit, because we do realise now pretty categorically that unfettered, the market can't provide everything that we need in order to deliver good health and social care. The market is an absolutely fundamental deliverer, but the market not unregulated, but the market uninfluenced by good commissioning and uninfluenced by the potential for developmental partnerships within the statutory, between the statutory sector and the market, it's not delivering what we need. And I can give you evidence of that, really. So whilst the April 2022 date is optimistically cited as the date that the bill will become law, it's anticipated that there will be delays because, as I say, it's getting bashed around in the Houses at the moment prior to it being done and dusted. So can we move on to the third slide? Many of us will have seen this slide before, and apologies to Deb, Roz, maybe Jeff, because you might have this slide in your slide deck. But it's an important one, and because I'm earlier on in the day, I get to pioneer it. But it's an important one as it clearly shows how existing systems are quite fragmented on the left. I use the term system advisedly, as they're not particularly systematic at the moment. They're not particularly integrated, although we are, as you can see by the middle element of this, we are moving towards much more effective and much better consolidation of our activity. But again, the systems are at the moment, as you can see, seen by being dominated by the hugeness of acute sector organisations. I think we have in COVID managed to move away from that a little bit. You know, that great focus on the targets that exist within the NHS, within the acute sector, to do with non-elective admissions and weights, and etc. They're not quite at the forefront as much anymore. And I think we ought to seize the moment of that, really, because it's actually the focus on the community activity and the ability of the community as part of a whole system to bring people out of the acutes and to bring people back home and support them more effectively. The provider sector, absolutely, utterly fundamental in that. It's that focus, that slight change that I think we're really welcoming in social care. It's quite a statutory reading, this one, and I've put at the top, where does the care provision sector fit within the model? Unapologetically, because this was designed at a time when a lot of instruction was coming down nationally to localities, to regions and areas, saying how we are meant to be delivering integrated care. But as we get more sophisticated and as we develop, we're going to need to be a lot less focused on the statutory element. I note the voluntary and community sector as part of it, but non-statutory community care provision isn't featured in it, particularly beyond being part of what is more broadly called social care. Now, from the council perspective, it's important for a couple of reasons not to just focus on the statutory sector organisations. Firstly, when you consider the well-used adage that only 10% of health and well-being is delivered through the clinical services of the NHS, and that the other 90% derives from a multiplicity of other places. So I don't want to underplay the absolutely essential nature of the clinical 10%, without which I'd be blind, without which several of my family members wouldn't be alive. So that's absolutely fundamental. But the point to make is when you're talking more broadly about healthcare and well-being, especially when you're talking about the potential for preventative activity to ensure that people stay well, stay happy, contented in their communities, it's that other 90% that we need to factor in to this model in order to make it work more effectively. So this is the council response, essentially, as the title of this was said. Secondly, when you consider that the adult social care sector, whilst nowhere near as big or costly as the NHS element, it's still worth over 400 million a year annual expenditure in Bristol, North Somerset, South Gloucestershire. A significant chunk, over 3/4 of that, which is committed to non-statutory provision, so to care provision that isn't directly provided by the state. So adding to that housing, education, unemployment support, benefits, transport, and the wealth of community support services that also are part of that 90%, you're well over £1 billion a year. Adding children's, there's a whole lot more. Adding the effects of COVID, there's a whole lot more. So there's actually a wealth, a hugeness of activity around the whole world of integrated care that is about things that are perhaps only touching or more outside of the components of that diagram that have to be factored in. Now, Chris touched on some of this, but I was quite amused yesterday because integrated care systems is the most recent drive towards integrated care, but I did do a little list of some of the other initiatives that there have been in recent years, and I thought it might be quite fun for people to remember them fondly for a moment or two. So Chris mentioned sustainability and transformation plans. Yes, the NHS 5-year forward view, happy with that. Long-term plan. The early better care fund initiatives, we're still on familiar ground here, Care Act 2014. New models of care vanguards, do you remember those? Or the integrated care pioneers? No, nothing around here, that was about 2013, I think. It's all the same idea, the same messages. World-class commissioning, does anybody remember world-class commissioning? This is like that comedy routine where you're doing I'll tell you what, it's when you're doing that comedy routine and no one recognises any of the references that you're talking about. It's funny in itself because you don't recognise them. That's why I'm enjoying this. Prior to that, local area agreements, common performance frameworks, Our Health, Our Care, Our Say. Does anybody remember Our Health, Our Care, Our Say? That was Patricia Hewitt time, I think it was, about 2007. I think that's as far back as I went. Oh, the NHS plan, that was about 2000, wasn't it, the NHS plan? But all of those have been broadly similar in their approach. I think this is probably the best crack that we've had so far at it and the most realistic means by which we might actually be able to make it real. But they've all been broadly similar. They've all been quite top down. They've all been quite nationally driven agendas. And I've always kind of said that top down's all very well, blueprints for success and all that. But actually, unless you develop things bottom up, they won't work. So that's where some of our locality work around here is actually much more likely to get things working more effectively, because unless people on the ground are owning, developing their own ways of doing things in the context of a big idea, it won't work unless they're doing that. So we've got to increasingly seize the agenda locally. That's the point that we'd make as councils. We've got to make it local, and in doing so, make it better represent the range of influential organisations and actors that make a difference in healthcare and wellbeing in the areas of Bristol, North Somerset, South Gloucestershire. So the next one, for councils, this is important. The essential issue of democratic accountability is key. As these illustrations show, the two main sectors that contribute to healthcare and wellbeing systems, as in the two statutory sectors, are politically overseen very differently from the democratic perspective. So local authorities operate under the immediate leadership of democratically elected councillors, and the scrutiny system's meant to hold work within all areas of the activity the council covers to account, primarily in the context of stuff the council does directly, although the health scrutiny function is quite important because it does oversee the work of the local NHS to an extent. The NHS proper, however, is not as locally politically accountable in the same way. And if you look at that on the right, actually, the nearest direct accountability is with the Secretary of State for Health and Social Care. And it's quite interesting because Julia Ross, who's been obviously one of the leaders in the health system, has said, I am democratically accountable, Sajid Javid will ring me up. And it's true, because you can in the NHS get called by the Secretary of State, and I think it's pretty scary. But at the end of it, there's that balance, because at the end, the councils involved in integrated care are really keen to recognise the importance of the local democratic accountability. And the new integration white paper does actually reflect that. Not only does it make clear that you can have council representatives on ICBs, on the boards, but it also suggests that locally elected people can sit on the boards, although it's up to the locality to determine whether that's the right thing or not. And those discussions are underway here, I know, but it does at least make that possible, which is an interesting point. So the next one, please. And I'll just say that given what I've said so far, given the ambitions of councils and their partners for integrated care, it'd be good to see this partner organisation slide. And I see David's looking at it very closely. And I'm going to say something that's going to please you, David. I've even got it written down so I can show you later on. But seriously, it'd be good to see this partner organisation slide in a couple of years' time. Because this is broadly built on the Healthier Together Sustainability and Transformation Plan partnership. But might the Care and Support West logo, and look, I have got it written down, that's exactly the words, might the Care and Support West logo be featured there? Or maybe some of the key developmental providers in the patch, may there be key providers featured on there in the longer term? That's up for grabs. It's up for us locally to determine how we develop this. So the next one, please. Briefly, Chris has covered a lot of this, but this slide outlines the structure of integrated care within the new system. You've heard about the Integrated Care Board. You can see we've got 2 integrated care partnerships, number 2 and number 4, because we've done that thing that Chris mentioned about our locality development work was called Integrated Care Partnerships from the outset. They've always been known as Integrated Care Partnerships. I'm not influential in this. Well, I am kind of, but not hugely. But it was somewhat annoying when a national pronouncement determined that the broader system-wide partnership board, the one which is similar to the Healthier Together Partnership Board now, it should have that name. I think that locally we're going to stick with ICPs though, because we got there first, you see. We named them ICPs first. That's probably may not happen, so don't take my word as gospel on that. That's just trying to, again, make a semi-comedic point. And it's underlined all the more by the fact that it didn't really get a huge response. Anyway, failing as a comedian is funnier than being one. Right, at least I'm clinging to that. The newest addition, though, is this concept of the place board. One for each council area. It seems to be a mirroring of the scope of health and wellbeing boards that already exist. And I know that Bristol and many other authorities don't necessarily envisage running place and health and wellbeing boards in parallel. But that does mean that we're going to have to work out what happens with health and wellbeing boards, because at the end of it, health and wellbeing boards have grown. People have had them since 2007, 2010. They started without significant statutory responsibilities. People have tacked things on like the Better Care Fund and certain aspects of integrated care since then. So health and wellbeing boards have grown as the agendas have grown over the last decade or maybe more. So it's kind of a bit up to us how we determine our place boards and what we do with them. So it's important to note the element of locality level budgets and commissioning at this stage. And I know that other people, I'm sure Ros especially, is going to talk about integrated care partnerships, our locality work in upcoming presentations. So I'm not going to dwell on it now, but it's important to note locality level budgets and commissioning at present being developed in the context of the new community mental health framework in the 6 localities of BNSSG. So can we just move on to the next slide, and you can see those 6 localities. Again, not going to dwell hugely on them. I'm sure you're going to probably cover quite a lot of this off. But, 1 for South Gloucestershire, 3 in Bristol, 2 in North Somerset. Quite varying in size, but interestingly, yeah, all kind of between that kind of 70, 80,000 to 200,000 mark, except for South Gloucestershire, which is quite a lot larger. So there they are. I'm going to just have a couple more slides now just on the particulars for councils. Can we move on? Yeah. So this one is just setting the council position in context, and Chris did mention this. We've seen increased national underfunding of social care for over a decade. To the extent now that that the solutions that are being offered for social care, the future of social care. Really, we are kind of wondering about whether or not they are going to enable social services and associated activity to be sustainable in the longer term, especially when, you know, the main solution for it was the levy that's being attached to national insurance. None of that's actually going to be available to social services until at least 2024. We've seen significant demand increases, especially during the COVID-19 era, and that demand, the patterns of demand have changed quite significantly. We've seen quite a lot of additional demand in mental health. In Bristol, the effect of that has been a 20% increase for the council in the number of people receiving high-level mental health services, you know, residential or high level of community support for mental health services, at a cost of about £4 million a year, which is enough for the council to push it over the edge budget-wise. We're also seeing quite significant workforce challenges, as I'm sure everybody in here will appreciate, so I'm not going to dwell on those, but that's becoming a perennial issue for us and a chronic issue. So this afternoon, after this, I'm going to go to the second sitting of Bristol's City Council's full council, where we hope to get the budget ratified. But that budget does include a quite significant around £20 million funding shortfall, which we've had to work to mitigate. And the majority of that £20 million budget shortfall is to do with additional spending in adult social care. So that's not, I hasten to add, a product of mismanagement or profligate and wasteful spending. This is a product of quite significant dynamics over the last 10 or 11 years that have created underfunding in social services. So we've developed some activity within the social services part of the council, working social services and then more broadly to try and address some of these things. You'll have seen in the integrated care piece the move to locality working, but we have actually focused all of our teams now much more on the locality approach, so that when other NHS teams, children's teams, etc., do the same, then we can start building these integrated locality teams that will be much more effective at meeting the needs of their communities. We are adopting standard operating procedures within our activity to improve our processes. Strengthening the local commission care offer. We've had quite a lot of discussions with the care sector about this and about our strategic plans in the longer term around reducing bed-based care, regularising spend, boosting the domiciliary and accommodation with care sector, and better local provision of high-level progressive services for people with complex needs. As I said, mental health spend has increased quite significantly in the last couple of years, but also we've had quite significant increases in the amount we've had to spend for people with learning disabilities, autism, enduring mental health, younger adults, and brain injury. And so those kinds of things, alongside dementia, are the areas where we're going to have to really boost our commitment financially. And then housing and accommodation is a big functional factor for local authorities, and we're going to have to do a lot more in that context to make general needs housing more available to people with perhaps adult social care needs, to develop specialised supported housing in order to support people more effectively within their communities, and also then, as noted just before, about high-level local provision, progressive provision for people with complex needs. So the last slide, and this is the kind of culmination of the council end of it, really, is this place bit and building the power of communities. And it's all about not only geographical communities, as noted, but it's also communities of interest. Bristol and North Somerset and South Gloucestershire, but especially Bristol, very diverse, culturally diverse population, and a very significant kind of range of needs, range of levels of wealth and prosperity in different parts of the city. So one size doesn't fit all for Bristol. We need to understand those dynamics, and we need to tailor what we're doing in communities and in places accordingly. And preferably, the more we can do that co-produced, as it were, The more we can do that in conjunction with the people of the community is by far the better, because that will make sure that the activity that we deliver is so much better tailored for people's needs. So the Mayor, Marvin Rees in Bristol, is very keen on this idea of the development organisation. A development organisation, and I'll read it, it says promotes equity, inclusion, community, social development and resilience. So that's about the council perhaps directly doing less, and it's about the council inspiring the development of more in other contexts. And I think that really does include the care provider sector, because that support and care that's provided outside of the council but paid for by the council is absolutely fundamental to this health care and wellbeing system. So we'd be looking for parity of status within those systems for the care provision sector, voluntary and community sector as well, and the means by which we can develop smaller and more representative local organisations to be better supported. We know that there's loads that we have to do as councils to cede responsibility and to help others to take responsibility. And it's all very well me standing here saying, yes, we want to cede responsibility, but organisations don't cede responsibility very readily. They resist it. Their systems, their professionality, their finance, their regulatory frameworks, they resist ceding responsibility. But this whole agenda is all about us doing that, because if we don't do that as a council, as NHS organisations, as providers within the system, we're not going to be able to make this work. So I'll stop there, but that's the council's response.
Thank you, Hugh. Are there any questions in the room in relation to the areas that Hugh's covered? Richard.
Hi, Richard Devison, Windmill Care. We're care providers in South Gloss. You've got provider written all over your slides, and it's brilliant, and you were very entertaining the way you presented it, so thank you very much. I think it made a lot of sense to a lot of us. I'm just concerned about the definition of provider and how we are then engaged within this system, and also the lower level, the planning groups. And how do you view us as a solution to your challenges that you've got?
Yes, I can speak probably better for Bristol than I can for South Gloss and North Somerset, although I think there is a lot that we do jointly and commonly. But I do know, for example, David, I know that you're involved in one of the locality integrated care partnerships in Bristol, the South one, and I know that we're increasingly trying to actually get people plugged into the conversations that are taking place in those localities. So we also, I mean, I've been quite keen since I've been here to set up and develop, or to build upon existing avenues of communication and to keep the conversations going. I've been very keen, for example, to give the provider sector more broadly upwind kind of knowledge about our budget situations, about our transformational goals, the imperatives, our commissioning plans and all of that kind of stuff, with the hope that bit by bit, incrementally, we can develop a more co-productive way of working. Now, David's always going to want, more, and rightly so, better representation on boards and things like that. And I'd back that argument, but we have done quite a bit already to start that. And I think the involvement in the South locality integrated care partnerships is an example of that, isn't it?
Yeah, I think so. I mean, for people sitting in the room who don't necessarily know everything that CSW, Care and Support West, has been doing, what we've done as a board is we put forward 2 people for each of the ICPs to sit at those tables. We've been successful with one, as you say, Bristol South. And the next speaker, Oona Goldsworthy, is that very person. So she may well say something about that when she does her slides. But I think from the Care and Support West and not just our point of view, the provider point of view, there's a real need for providers to be represented, not only there, but also on the ICS. And that's something we've been pushing for as well. And I think that from a provider perspective, when we get people sitting at those tables, what our responsibility will not only be to have that learning come back into the board at Care and Support West, but also out to the provider world, because we link with a whole pile of people. Our comms goes to the better part of I don't know, 550, 600 providers of care across the 4 old unitary authorities for Avon. So we need to continue doing that. There are a range of questions that have come up on the chat, but what we'll do is we'll capture those and we'll get them for those that, we'll get them to whomsoever it applies to.
Absolutely.
And you can maybe respond to those after the event today, Hugh. Are there any other questions though in the room?
I wondered whether it would be more your question than.
Even though he's a comedian.
I'm a failed comedian.
That was said with much love, Hugh.
Thank you.
Okay, then I think we'll probably move on, shall we? Thank you very much, Hugh. Do we have Oona up and ready to run?
Hi, everybody. Can you hear me? I can't see you, which is very disarming. But is that okay? Yeah, fantastic. Firstly, huge apologies.
Yes, it's fine.
Sorry, huge apologies for me, everybody. I really wanted to be in the room today. I was really looking forward to it. The dreaded COVID 2 years in has hit me, and it's really not very nice, I have to tell you all. Many of you probably had it already, but so please bear with me. My voice is a bit rough this morning. So we have really rehearsed it, Chris and Hugh and I have really rehearsed what we're going to say to you this morning, but really not. Amazingly, there's some very strong themes that I'm going to be able to pick up hopefully from the previous 2. So can we have first slide, please? This should now work. Have we got it? Thank you. First slide, sorry, can we go back one? So a little bit about me. So I'm Oona Goldsworthy. I'm Chief Executive at Brunel Care. Many of you will know us, but those that don't, we have been going for over 80 years and we provide care and support services for over 3,000 people every day. We've got a range of provision which includes care homes, residential care, reablement centres, independent housing association as well, and so on. So we provide a whole range of different services, mostly for older people across the west of England and Somerset. So next slide, please. And I'm going to provide you with a little bit about the provider perspective. So completely coming down to where we talked about in terms of we've got the overall system, then you've got the boards and we've got the local authority. And I'm going to talk about it from a provider perspective, being involved in one of the integrated care partnerships. And to take Chris's point, we're terming partnerships as being the place-based part of the system. And I just want to start off with really why it matters and why does integrating care and health matter. And I've used this statement from Social Care Futures, which really just talks about how important home is and how important communities are in the sense of what matters to us. And I think this says it really, really well. And Social Care Future represents people who are representing people with lived experience in using social care. And I think it's lovely. Next slide, please. Can you see the slides? I'm getting some comments that you can't. Hopefully now you can. So why does social care matter in the integrated care system? Well, I think it's what it says on the tin, isn't it? Integrated care. Yeah, good, you can see the slides now. So it's about health and care. And why social care providers? Well, if we look at what we do as a sector in terms of our provision, we've got over 25,000 people working in social care in the BNSSG area. We're looking at real issues about population health and that community. And I think Hugh's point just then about 90% of the community health is actually done in the community rather than the acutes. And I think, whereas at the moment, often local authorities represent the voice of providers, at the end of the day, they're the commissioners, as Hugh's just talked about, and we're here to look at what we can do as a sector rather than just in terms of what we're commissioned to do. How we've done it and how we've started to organise ourselves is through Care and Support West, and thank you for David for organising this conference today. And what that's done is given us an accountability structure where we can nominate people like myself to sit on those partnerships. I think I'm the first, but hopefully there are more to come. And so I've been sitting on South Bristol ICP since last October. Excuse me, it's been going for a lot longer than that, but I've joined it since then, and I'm going to give you today some of my reflections, and hopefully that will help others to know how we might work together in the future. Next slide, please. Excuse me. Many of us, and this is a lovely picture of our wonderful Southmead Hospital, which has fared me and my family very, very well over the years, and I'm very grateful to it. But for many people, when we talk about health and care, we have a vision about a hospital and about acute services. But, and my next slide, please. And I love this saying about health is made at home and hospitals are for repairs. And good health comes from all these pictures and images that I put up in front of you. So whether it's friendship, whether it's community, whether it's good food, whether it's good housing, whether it's connections with others, that's what really drives our health and really drives our sense of well-being and who we are. Next slide, please. We've seen this chart already a bit, so I think Hugh gave us an image, a slide about how it all fits together. It's far too small for you to read, but if you can just make out the South Bristol ICP board, underneath that, there's a whole plethora of other things which I'm going to talk a little bit about in a minute. But you can see there's a structure which is very much starting to form about how we drive down in terms of delivering better health outcomes in our communities. Next slide, please. So a bit about the South Bristol ICP, which will probably be a mystery to many of you. I think some of the members might be in the audience or on the call today. We have been, I think it's fair to say, forming, norming and storming. We don't have a model. There's nothing that we can pick up and use in terms of what's been done before. So we're very much trying to come together to look at what our role is, what our identity is. And we've come up with a collaborative agreement, which we've been struggling with for some time, but it's coming together. It will change. It's very much the start of that. But what it's doing is bringing together, perhaps for the first time, a range of partners from the community. So we have voluntary sector organisations such as BS3 and the Northwest Health Park, social care providers like myself, local authorities, GPs, AWB, Oona, acutes, and people with lived experience as well. And together, what we're trying to do is to form what we think and how we articulate what some of those health needs of our Bristol South are. We can't do it all, and a little bit later, I'll reflect on what we can and what we can't do. Next slide, please. What we've done so far, so in the time that we've been going, we have had a number of jobs, if you like, to get on with, and that's been quite good because it's helped us coalesce around certain actions. So we've been looking at the recommission of community mental health, and a number of projects and initiatives have come out of that. For example, community connectors, peer support, the IPCTs, which don't ask me to explain. I wasn't involved in this bit of the work because I joined just as it was coming through. But there are some very small, tiny budgets, but tiny little projects that could grow and could end up as a model for other areas as well. Ageing Well, a massive national project, but very much held by the NHS, I'd say, and starting to cascade that down to us in terms of South Bristol. So a lot of it's already been sorted, if you like, and it's very hard for us to actually access it. But we're starting to take some of the ideas that are coming through that and look at how it relates to South Bristol, and particularly how it relates to prevention. And then the other things, and actually I think this came out in Hugh's and Chris's presentation, was about data and evidence. Where do we drive that data? You've got some of the raw data that perhaps comes through anyway in terms of population and census and demographics, but other stuff is coming through about that anecdotal stuff, what the GPs are feeling, what the communities are feeling, where the real pressures are, what's working in practice. And I think having that feedback loop that we feed back up through the system is going to be incredibly valuable. And some of it will be anecdotal and not but actually having that base about how we use that data and evidence, I think will be hugely important. Next slide, please. So, right, this is me now personal, and this is my very, very personal reflections. And I think we're very much at the norming, storming. No, we're not storming yet. Norming, forming stage. We haven't started storming yet. But some of my reflections are, and I've listed some of them here, I won't go through all of them. Sometimes I come away from our meetings and think, I have no idea what that was about. It can feel really messy. It can feel quite frustrating for none of us, certainly not my day job. It's not our day job. It's something we come into and we try to influence. We've asked ourselves masses of existential questions. that whole sort of, how am I accountable? How can I represent South Bristol? I grew up in South Bristol, but actually I don't live there now. How can we possibly influence other organisations? Other colleagues from bigger organisations like Oona have said, how do I influence my own organisation? How do I make decisions about this? And then I think then our relationship with the rest of the system, and actually it's been quite heartening to hear today that willingness and the importance perhaps that is being driven about place, because we don't always feel it. We can often feel done to and ignored by the rest of the system. And certainly we don't have a good understanding yet, I'd say, about our feedback loops or how we're accountable back into the ICS and how they're accountable back to us. So I think there's still lots of things about governance and control that we've still got to work through. Next slide, please. But, and this isn't a qualified but, it's a very positive but. I've joined it, and actually I will say that I've been learning to listen and not telling. So not going as an advocate for providers or social care, but actually thinking, okay, that's how that works. I think it's very unusual to be in a situation where I'm listening to a practice manager and a GP tell us what it's really like on the ground, what it's like for community nurses, listening to the community organisations when we come up with statements like, oh, that's a good idea, let's get the community to do that. And they're saying, hang on a minute, where's our capacity in this? And from that, it's starting to become what I'd say quite rich relationships and trust. And we've had over the last couple of months some what I would say light bulb moments when we've got together in smaller groups and thought, actually that could work, we could do that. And particularly around the ageing well and some of that hyper local work. And actually, why don't we just try it? And things like shared budgets, if only we could share budgets. I'll give you an example. So we operate home care services, domiciliary care. And often we might have, our guys going in to doing care 3 times a day. We might have a Oona nurse going in twice a day. We might have the GP visiting. And actually, can't we just join some of that up? Do we have to replicate it? Because it certainly isn't providing the best joined up service for the residents that we're looking after. Next slide, please. And why is it important? So I'm going to sort of finish. I've got two slides to finish. Why is it important that providers are involved? I think I'm probably preaching to the converted here, but I think it's a two-way process. And as I said in my previous slide, I don't think it's us just as social care providers saying, you need to listen to us, we know best. I think it's about us learning back. And so that's important for us by what we hear. But we do have, I think, learnt experience and a long track record in dealing with and responding to some quite important issues which have very long-lasting health outcomes. So, for example, our work around dementia, we've got a number of care homes. We care for people with quite advanced dementia and complex dementia. Well, we've got that experience. Why don't we share it? Prevention and falls prevention, wound dressings, all those sort of things which we could share. We don't have to keep to ourselves. And pooling that knowledge and coming together to say, this is what we can do together using technology and AI, for example. And my next slide, please. And my ask is, I want to just finish off with an ask of the wider system. The voluntary sector are key partners in the ICS and have a recognised role, I think, within the board and the partnership. I would argue that there needs to be representative from social care providers, and I think that's come through this morning, hasn't it, quite strongly. And why? And I think it's because the well-being of our community is at the heart of that, and that's what shapes good health. There's a real opportunity there to work within the ICS, not as a recipient of information, but as co-producing and testing and learning some of the things that we can do. And I think using that inverted pyramid as a model, that we're here to serve our citizens who are at the top, and we must always remember that. I want to finish off, and it has been mentioned, but we're just, and this is also a bit of a plea back up to the ICS system itself, and I know Hugh will be very well aware of this, is having not going to have the benefit of the national insurance levy for social care for some 3 years or possibly longer. We're going into this year to design a new system for paying for care, which is quite profound. And I think that that is going to shape the resilience and possibly be a good thing, but possibly also threaten the sustainability of many of us as care providers across the country and across the west of England. So I think allowing us to have those conversations from a very open and transparent way within the ICS and the partnership boards is going to be key, because it is really complex. And that if we don't get a grip on this and we don't look at it as a whole system-wide response, never mind all the endless winter pressures and gold command, silver command conversations that have been going on over the last 6 months, we will really be in crisis. So it's a bit of a plea to say, can we just head that off by making sure we've got that voice of providers when we come to those conversations. Thank you. And that was my last slide.
Thank you, Oona, and thank you lots and lots for braving the C word and still being with us. And we hope that you improve soon, and that won't take very long before you'll be up and running again. There are a number of thanks to you on the chat, and in particular, where's the one from Mick? Where's it gone? Here we go.
So I'm not a very good patient. Those of you who know me will know that I'm not a very good patient. And I tell you, this COVID, it's nasty.
Yeah, indeed, sir. And we feel for you. Lots of people in the room, I dare say, have been in the same place as you. Happily, I haven't, but thank you for doing what you're doing this morning. Mick, who's also from Care and Support West, says, really useful, thank you. On the ground learning conversations has to be the key part of these partnerships going forward. Nice to see these conversations starting to happen and to hear about their value. And Oona, thanks. You're part of the Bristol South ICP, and we're hoping that one of the results from today will be that Jeff and others take away from the meeting here today the significance and the central importance of social care sitting at all of those tables. So we're really looking forward to hearing from Jeff and others in the second part of the session today. So we've reached the end of the first bit. So thank you for the speakers, all of you, Chris, Hugh, and Oona. I'm going to be handing this microphone for the management, if you like, of the second part of the session to Holly Hardy, who's a local GP, and she's the clinical lead for the training hub. And the training hub are kindly partly funding this event today. So we're doing this in partnership with them. So now's time to leap back and eat all of those croissants and have some more coffee and tea. And we'll get back going in about 15 minutes time. Thank you very much indeed.
Morning, Chris. Just checking you can hear it all right. That's good. I'll go back on mute until you give me a nudge.
Hello, everyone. Can you hear me okay? Give me a thumbs up. Yeah. Is it okay if we get back to business, as it were? Everybody looks like they've got a coffee and a pastry, which is very nice. So I'm Holly Hardy. I'm a GP by background in Bristol area. And I'm here as the clinical lead of the Primary Community and Social Care Training Hub, which is how I know David, who's very kindly asked me to join you today. So I've been really pleased to hear the talks this morning, and we've got 3 other inspiring speakers to go to finish off the morning. I thought I would start with a little story about my day at the practice yesterday, which stuck in my mind. So I had a phone call from an elderly demented patient who lived alone, and she was very confused. She'd just come out of hospital, and we had a chat, and she repeated all the same problems that she'd had when she went into hospital. And I said, well, you've had all your tests done, and I can look on the system, and I can see all your blood tests and your urine tests, and they're all fine. She said, but I feel terrible. And I said, did you feel like that when you were in hospital? Yes. Did you feel like that when you were on your way home? Yes. Okay, so we agreed on a plan that we would look at how she could be better supported at home, but there wasn't any sort of emergency for today. Anyway, about an hour later, she phoned back. There was a list on a call on the phone list. I thought, that's a bit strange. I've just spoken to her, so I ran her back. I said, Evelyn, what's the trouble? I just spoke to you an hour ago. She had no memory of that whatsoever. But she said, there's 2 people in my house and I don't know who they are. So I said, well, can you put them on the phone? And somebody came to the phone and said, oh, hello. I said, who are you? And they said, oh, I'm from Oona, community provider. Come to help Evelyn. I said, okay. And who's the other person that's there? Well, somebody from social care that's come in as well. And Evelyn was still ringing the GP, so it made me think, somehow we've got to do this differently. But anyway, sorry to take over with a little story, but I thought that put things in context. So the things I heard from this morning, I was really inspired, actually. I thought Chris gave a really great overview. I don't understand what's going on, to be honest, despite all the reading I've done and being a GP. So that gave me a really good overview of what was happening. And I heard from that about the importance of collective responsibility and the knock-on effect. So if social care fails, then that knocks onto health, doesn't it? So we can't just all do our own sort of bits in isolation. And then in terms of Hugh, I heard about seizing the moment. So there's sort of that positive, this is the moment that we've got. COVID-19 has kind of shone a spotlight, hasn't it, on not only inequalities, but looking after patients in the community. Let's grab it quickly before the door closes. I did feel a bit of tension there between council and providers. I'm not kind of privy to the politics perhaps of social care, but I also did hear a willingness to sort of work together really and to get a solution. And finally from Oona, I felt really positive to hear there's some green shoots, tiny little shoots at the sort of place level of people starting to work together, but they really are tiny green shoots, aren't they? And there's a huge way to go. And a plug, if I may, from the point of view of the training hub, just very briefly. I can see David looking at me sternly, stop talking. But my colleague Wendy, from the training hub leads on placements, and we're looking at models of doing student placements, so growing the future workforce, which we know is a big issue across health and social care. So how exciting if we can do that. And please put your hands up and volunteer if you think your organisations might be able to take some amazing students that could be your future workforce. Is that okay, Wendy? Perfect. Excellent. Have we got Deborah ready?
Yes, I'm here.
Get an echo now. Hello, can I just introduce, I'm getting an echo, is everybody else hearing okay? Or yeah, so this is, can I introduce Deborah El Said, who's the Director of Transformation for Bristol, North Somerset and South Gloucestershire Clinical Commissioning Group. Welcome, Deborah.
Morning, Holly.
I wish you were here in person, but we can see you and hear you, so that's amazing. I picked up something from your Twitter account, Debs. I don't know if it's fair to share it, but it says you're passionate about mental health, digital tech, and making stuff better. And I really liked the final comment. So may I hand over to you, Debs, and if you want to give a wider introduction to yourself, please do.
Thanks, Holly. Really nice to see you. And I loved your story And I think that kind of, it's those human stories that remind us what we're here to do and why some of the challenges that we face are just so important. So, so yes, I'm the Director of Transformation. Just to kind of give a little bit more context across the system of some of the things that I'm responsible for, which has kind of shaped some of the things I wanted to talk to you about today. So I'm responsible for digital as the SRO across the system, so bringing together all of our digital endeavours across health and care to be able to support our overarching mission and priorities. I'm also the SRO for mental health. My background is mental health and learning disabilities from many, many years ago, 31 years now in the NHS. And the final thing that I'm responsible for, which I think is really pertinent to your story earlier, is integrated care. And if you could just flick onto the next slide for me, colleagues. One of the things that when I talked to David, he wanted me to talk through was some of the things are challenges. And rather than just focusing in on the CCG as the commissioner, obviously Jeff's spoken to you this morning about how things are changing. I thought what was really important was to have a conversation about our shared challenges. And the fragmentation of care is one of the things in my 30 years, I've often been responsible for public facing communications and engagement with the public. And the things that I have heard consistently throughout that 31 years is, can't we join things up a little bit better? You know, I was part of an MDT many years ago with health and social care, where it was so long ago, we only had bits of paper in folders and we didn't have any digital systems at all to support us. But one of the things that's really critically important that people talk about is often not the care that they receive, but the journey of getting to care. The journey when you're older and you have complex, multiple conditions, where you're trying to kind of piece together elements of the care, the treatment and the support that you need. It becomes really complicated and overwhelming for people. And that often percolates through to staff groups. So you hear staff groups talking about some of their biggest frustrations. And sadly, I'm sure it's still the same today, that the things that people get frustrated about, where we drain our valuable assets, is when we create mechanisms that act as barriers and thresholds between services, where we're constantly assessing, is this person allowed to have this service? Should that person go somewhere else? That process for people is frustrating and complicated. And many of you in the room today may well have experienced this personally, be supporting family, relatives, heard stories, or kind of encountered it significantly in your professional lives. And this is one of the things that is our shared challenge. You know, the seizing the moment. This is a time where the integration across the health and care system and across broader partnerships is now not an option. It's now not something that we do because it's a helpful thing to do. It's now mandated, and it's long overdue for us to really work together and start to think about, how do we bring all of the assets that we collectively have across the health and care system, the independent and the private sector, the voluntary sector, social enterprises, and our communities, and the person themselves, to connect and develop a team around the person that supports them as close to their community as possible, the place that they call home, and really starting to think about how that team around the person changes from a set of referrals onto some linear pathways to be able to access care, but rather something that creates a system of support around the person that considers that needs are not, that they don't always have a start and finish. They change, they go through the life course, they ebb and flow. And those needs are not just about health and care, they're influenced by the wider impacts of the person's lives. And in order to do some of those, and I'm wondering, Holly, I wasn't able to join you earlier, whether you were talking about some of the green shoots that Oona was talking about earlier. And I'm hopeful that some of that stems from the work that we've been doing around place-based partnerships, and some of the work that I know Ros will be talking to you about a bit later on. But that is really the opportunity where we've created agency for multiple organisations to come together, including the VCSE, as well as statutory organisations, to think about how we can provide a different model of care around the person. using all of our assets differently. And of course, you know, digital technology and data will also be a critical underpinning enabler. And it is an underpinning enabler, not the point of what we're trying to do, but to enable us to start to connect up services and understand, for example, where we've got challenges or issues around beds, placements, staffing, at any different component of our system. We need to get a much better sense of how we join all of that up so that we can start to make sure that reflects the needs and the system of support that the person needs to be able to optimally support them, but also so that we know we have a finite amount of money, and whether that's in the NHS around health, whether it's around social care and local government budgets, or whether it's also about the contributions that the individual makes, where we're talking about people paying for their own care in the future. There are finite resources. So we need to think about how we optimize those to get the best outcomes for people. And I think one of the points that I did want to make on the fragmented care agenda is that we are making some progress. Some of the partnership work that we've been doing, and I think particularly around connecting care access by our nursing homes and care homes, you know, we're starting to get into a position where we're really blazing the trail with this type of connection. And I think at the moment, we're probably about 20 or 30% of our homes that are starting to use Connecting Care. What we've tried to do is to make that access much easier, so that where we have situations where things feel fragmented because maybe the discharge summary hasn't arrived, the letter from the acute hasn't arrived, the GP's prescription people aren't clear about, that actually we've got a place so that we can make sure that our care homes, our dom care and our nursing homes are really connected into the individual space that enables us to understand what's going on for that person. So whilst it's a shared challenge today, it's also a massive shared opportunity, and one that I kind of wanted to flag today and be really interested when we get into some conversation about how things feel and what we can do to accelerate and do more in this space, so that we do have a future when we start to have an increase in our aging population, that we can start to think of some new ways that we're not wasting time on the disconnects between care, frustrating our staff who are trying to bridge the gap when care is disconnected, and of course the safety implications for people when things are disconnected, but rather we're injecting that energy into bringing all of this together. If you could flow on to the next slide for me. And of course, we cannot ignore the massive challenge that we have in terms of workforce. This is something that we are connected to. And actually, as I was driving into Bristol this morning, the Proud to Care banner was there in terms of thinking about how we start to ensure that we have a high quality workforce and change the way that we perceive the careers of caring. David and I had a really fascinating conversation about some ways in which at a societal level, we know that there are ambitions to do this, but what can we do in our local communities? What can we do across BNSSG to start to drive up that sense of a career in care is one worth having? And I'm one of those people who started out, so I've worked in nursing homes through my career. I started out and worked my way up through a caring structure into the NHS. And I think it's really important that people see that there are frameworks that will help them to turn a career in caring into many different opportunities. But having a high quality workforce is dependent upon the availability. So connecting with, you know, Holly was talking about the training hub, is critically important. Some of our assets in this system around our universities and things like Western College, who've got a great opportunity to start to consider people who maybe wouldn't have stepped into a space that a career in caring, helping us to think about new ways to draw new entrants into that. And of course, it won't be enough just to think about attracting a workforce in. It won't be enough to think about simply how we find different ways to recruit people. We need to think about new models of care. We've already started with virtual wards, and I think it's almost 1,000 people now that we've cared for in the great work that colleagues across the system have drawn together in terms of virtual COVID wards. But thinking now about how we use technology to support and augment care. There are so many advancements. We've got one of the biggest robotics labs in Europe right on our doorstep. In UE, we've got an Internet of Things hub inside the University of Bristol. There are amazing things that we can do to consider how technology in the third age can support people, but also can start to help us think about different models of care that enable us to address the fact that our workforce is going to be challenged. And I think the training opportunities for new roles as we start to move into the ICPs, the place-based partnerships, and thinking about the team around the person, what we can start to do is think about what can be done with the support and oversight and supervision of a clinician that can be done by someone who doesn't need to be a clinician, but bringing together the skills and valuing the skills of each of those components of a professional team around the person is going to be really important as we go forward. And starting to think about each of us as leaders, starting to think about how do we bring our teams together to think about themselves being a seamless, frictionless workforce. Plenty of work to do in this space, but starting with some of those ambitions, as I'm sure Jeff has highlighted for the Integrated Care Board, is really critical in terms of how we create sustainable health and care for the future. And then if you could go on to my final slide. Thank you. And of course, we are living longer, which is, it's not a challenge, it is something to be celebrated. But we are living longer with more conditions. The advancements in health and care enables us to live well. So in terms of those DALYs and QALYs, in terms of how we measure active life years, those are changing. And that concept of aging well, so starting to think not just about our population who are already in a category where we might classify them as being frail, but how do we start to think about how we avoid that? We know already that 3 long-term conditions, when you hit that 3rd long-term condition, the likelihood of becoming frail escalates to 80%. So starting to think about how we have that aging well concept, along with the other 2 elements that I talked about, because this all has to dovetail together, to start to think about how do we keep people, how do we all stay as independent as possible, and enable us to be able to think about how we stay in the place that we call home for as long as possible without needing urgent care, without needing the support of others. But when we do, making sure that we've actually thought about that capacity and demand model so that we're thinking about the ability to create that urgent community response, which is these 3 tiers of the current Aging Well programme are really important to put in place as foundations. And making sure that our anticipatory care model that thinks about how we use our population health data and share that across all partners to understand how we create the best interventions and opportunities for people with very complex needs. You know, we know, for example, in dementia care and things like motor neuron disease, there are some amazing things that we can start to do early on. I saw something quite recently about people recording their voice if they know that they're going to lose it with the advancement of disease. Some of these things will, we hope, become embedded in the way that we expect to receive services. So starting to think about the changes in demands now so that we can start to shape some of that and build those programs of work and initiatives that bring us together and allow us to enhance the care that we're all able to deliver. And I think the final point on the slide is about the enhanced health and care homes. Through COVID, the connection with primary care, and I'd be really interested to hear about people's experience of that, but we've known for many years that the connection between care homes and nursing homes and primary care is really important. It's a really strong connection. We've seen examples of where it works really well and people are connected, that we can deliver transformed outcomes for people and staff have a better time and the whole system works to a much more sustainable and improved outcome type model. So I think my core message is that we have some shared challenges, and I'm sure it's building on Jeff's points from earlier. But by doing this together, by taking the time to understand each other and the challenges that we face individually and connecting on the shared challenges, we are more likely to deliver better outcomes for the entire population and the people we serve both now and going forward into the future. So I will pause there and take any questions. Thanks, Holly.
Thanks very much, Debs. Interestingly, we hadn't touched base together, had we, before you came up with the theme of fragmentation of care, and I presented my story from yesterday. So there's obviously a lot of it about, but I hear what you say. It's really important about having the team around me, and that digital and technology can facilitate that, but it's about the people, isn't it? It's the people that give the care. So I just wonder, has anyone in the room got any questions for Debs? We've got a microphone there. Does anyone want to put their hand up and ask a question? We'll have a look on, oh, David's got the microphone. Go on, be brave.
Or make a comment. I'd love to hear your thoughts. I'd love to hear to be a question.
3 long-term conditions giving an 80% chance of being frail is quite scary, because I'd say most of my patients have got 3 long-term conditions. So your clients, service users, I'm sure it's the same. Anything in the chat or anything? Oh, yeah, do come in. Did you hear that, Debs? Okay.
No, I might need you to repeat the question for me, Holly.
Having the ICP help to professionalise social care. I think that was picking up on one of the points you made.
Has it? Is that the question? And I think it's probably too early to tell. I think what we're really excited about, and if Ros is in the room or presenting later, it would be really good, because she's actually a social worker herself and is leading the development of the ICP across Western. So I don't know about professionalising, because I think there is already a profession, but I think what it's starting to do is to help people understand how we can work more connectedly together and deliver better outcomes, rather than thinking about a person needs a health intervention or a social care intervention. And this takes me back 30 years or so, because it's not about whether someone needs a health intervention or a social care intervention. We all need both, and wrapping that in a way that builds on the assets and the capabilities around social care. And I think what we have found is a lot of learning. So the team around me concept has kind of come from social care, and I think we're adopting it into healthcare. And that's one of the things that I think is super powerful in this space. This isn't about, you know, the NHS primacy that I think we've seen in years before. This is about really learning together and understanding how we can do more for people with the resources that we have. And it isn't all about medical intervention. It isn't all about medication. And I think we know that we've over-medicalised in places, and that's what we need to make sure that we address.
Thanks, Deb. I think we've got a question from Hugh.
Yeah. Hi, Deb. You all right?
Hello.
Never met Deb. We've been working together for 2 years.
We've only ever met on Zoom.
Yeah, just to elaborate. Sorry. Go on.
No, carry on.
To elaborate on that question, because, you know, I think you hooked onto it in the context of social work, but I'm quite interested as regards the thousands of care workers that we have working in the system. And I think the professionalised bit for me is all about how can we make a more respected career, and not that it isn't respected, don't get me wrong, but how can we get a more kind of a career out of it, or a set of pathways out of it that'll encourage more people. You alluded to it in your presentation, but it'll encourage more people to take part, make it more worthwhile to do that, as opposed to earning £1 an hour more in Amazon or whatever.
Yeah, and I think there's a number of things. There's a leadership task for all of us as system leaders to make sure that we consider that. And then there's a day-to-day task of understanding the value that carer adds to that person's life, because they're the people often, if you think about key workers and care coordinators, they're the people that actually know that individual best. And if we start thinking about the team around the person, it's about hearing that voice of that carer to be able to understand what does the person need. So I was talking to some good GPs quite recently who, as part of the ICPs, have spent some time with some carers, and it helped them with some really complex, people with some really complex needs to understand better what was going on. Because otherwise, Holly, as you know, you could make an assumption that there's a medical challenge going on, but actually what you don't know is actually there's something that's going on in that person's life that the carer will understand and know about, that by sharing that information, you have much better insight into how to support somebody. So I think, and having been in that position myself personally, where you think, yeah, you're all talking about this, but you don't actually realise that what Janice needs is, she's got autism and she gets really stressed when we change easier, and she gets much less distressed. Those things are really important, and we must make sure that we create an environment where we consider the humanising of the way that we talk about health and care plans, and the support that we wrap around people to keep them well and independent. And it's also about things like, this is kind of close to my heart because I struggle with this, but saying to somebody you need to sort your BMI out, well, that's very complicated and difficult. But when you actually talk to somebody who says, do you know, I really want to go out and walk my dog again, that's what matters to me. Building a plan for that person to achieve their goals. And that's often something that carers who have time to connect with people and who are listening to that human side of things will find that sometimes busy clinicians or others might miss, not purposefully, but just because of the nature of the conversation. So we have to start things because they actually connect to delivering outcomes.
Thanks, Debs. I just reflect specifically and answer the question about careers in care. Last year at the conference, one of the speakers, David may remember, who talked about micro-credentialing. I really like that idea because I think if you make it a need to be a professional in some way, that's not for everybody, but actually if you can gather sort of bits of towards a career pathway, then that can be helpful. So just throwing that in there. Thank you,
love
Debs.
that micro-credentialing. Have we done something
burning
on that
in the chat, or in the interest of time, should we move on to Ross? Yes, that perfect. I was very remiss, and I do apologise. I didn't welcome everybody in the virtual space, and David specifically reminded me. So I'm so sorry. Welcome to the majority of you who are not with us today, as well as our lovely guests in the room. So let's move on. If I could introduce Ros Cox, who's Delivery Director, Integrated Care Partnership, Bristol, North Somerset and South Gloucestershire, with a responsibility for Western, Wirral and the villages. So and if you want to give a bit more detail, Ros, please do. I'll just step aside. Thank you.
Everyone, gosh, it does feel strange up here after a good 2.5 years, doesn't it? So my name is Ros Cox and I'm Delivery Director for across Bristol, North Somerset and South Gloss, but also with particular responsibility for Western, Wirral and villages. So if we can have the first slide, please. So I'm probably going to apologise now for saying all of the things that have happened and you've all mentioned before around what are integrated care partnerships. But we know that our ability to stay healthy and well depends on a range of things, including social connections, employment, housing and education. So we know that if we want to really make a difference in people's lives, we've got to really start to think about those wider things that happen in people's lives and bring those together. So our integrated care partnerships are very much thinking about those formal partnerships that we can have and thinking about how we can deliver care by collaborating rather than competing. Please. So I think Hugh stole my thunder here with this slide, but this is the slide across Bristol, North Somerset and South Gloucestershire. And as you can see, Western Wirral and villages down there and at the bottom, which we often get forgotten about, but really we shouldn't. So really just to say that across BNSSG there are 6. This has been mentioned before, but really starting to say that these are how these are spread out. And I think if anyone's paying particular attention, the population for each of the areas are actually more on my slide than everyone else, the last one that we had, but they've just grown a little bit since then. So next one, please. Okay, so who makes up the Integrated Care Partnership? We've gone through this, I think, this morning. I think just to mention, I think I've read somewhere that if you hear something 7 times, it eventually manages to sink in. So I think by the end of today, we'll all really get this bit. The people that are involved in the partnership are general practice. It is around social care, NHS, hospitals, the voluntary sector, councils, and other community services. And we're all working together very much as equal partners. So very much we see our integrated care partnership as one team. when we're really applying our expertise collectively to really start to think about how we can improve lives for people and improve outcomes. So each ICPs are really starting to understand what matters most to the people in their populations. And I'll come on in a minute just to think about how we're doing that, particularly in Western. Thank you. So our main objectives, definitely collaboration is at our heart. We really want to improve the health and care of the people that we serve. We really want to make sure that everything that we do is for the benefit of our local populations. We definitely want to reduce health inequalities, of course. And also we want to make sure that we increase the number of years that people live in good health, and make sure that we help and create the communities to help people to do that. And we've heard already this morning about ICPs being the community as the default for care for people, very much using hospitals just as a temporary measure for people to go in when they need it, but very much that focus out of acute hospitals and very much in the communities where people live. So I think just to say that I'm not going to go through all of this slide, but I think that we're very familiar with some of how we can make a difference for people's lives. So person-centered care, I know that everybody will be familiar with that term, but it is very much some of the terms we've heard here today. What matters to me, team around me, how do we really start to focus in on the person and what matters to them? We need to make sure that the way we work is very proactive. So we really need to see the person as a whole person. Bringing out their strengths, understanding the assets, what do they bring to their communities, as well as what can they get from their communities. And also making sure that everything is place-based. So we've had recognition that communities aren't just place-based, they're communities where people feel connected as well. But we also really want to make sure that we're homing down, certainly initially, on the places that people live and what specifically is important to those communities. So how will this make a difference to us? And by us here, I'm kind of thinking, how does it make a difference to people, the professionals and people that are working within the partnership? So we really want to make sure that we can work productively together as a fulfilled workforce. We really want to make sure that our organisations will be closer than ever, and how we work together will be closer than ever, and that we'll be starting to think about sharing resources and also learning and having shared experiences. And we really want to make sure that we make the most effective use of our existing resources, so that most importantly, we can bring about change in people's lives. So yeah, how are we rising to the challenge? And this is a challenge because we've been trying and thinking about how we integrate care for, as we've said this morning, for many years. So I wanted to share, the next slide please, some examples of how we're doing that. And I wanted to just focus down, and I've got a colleague here, Steve Ray, as well, from South Bristol. So I don't want to just talk about Western Wales Villages if he wants to chip in, but I have thought about how I can share some of the experiences that we've done within our partnership over the last few months. So first of all, we're looking at our needs of our population, and we're starting to look at some of the population health data down the side there for each of our areas, to think about really what's making up the area that we're working in. I won't go through all of that now, but that's very much what we're looking at in terms of levels of deprivation. How many people do we have in our area with particular mental health issues? So for Western Wales Villages, for example, we have a high number of people with personality disorders. That's not come through on that, but we have a lower percentage, for example, in BNSSG with people with eating disorders. So we're really going to have to think about kind of where we want to focus our attention. Next slide, please. Okay, so what have we done so far? So we've had a look at some of that population health data as a partnership, and we've decided to think about how we think about our priorities going forward. We started working together to improve our community mental health services, which is the first stage of ours and every ICP across BNSSG. It's very much looking at our mental health framework and how we're going to work differently within that. We've completed a target operating model. So as partners, we've all sat down together and said, how do we really want to deliver good mental health services for the people in our population? And we've started to write that down and work that through. So that's been really useful. And then we're in the process now of doing a partnership agreement. So we're going to have, thinking about some of the structures we saw earlier around the board and partnerships and how we work together as senior leaders and how we come together for that day-to-day sort of decision making as well. And the last one is that we've been really starting to make links with our health and wellbeing boards and working through some of those things. For example, the health and wellbeing strategy in North Somerset. We've been linking up really clearly with the council there around how we can make sure that that set of priorities is across the partnership, and really sort of understanding where partners can lead, and the council, particularly within the health and wellbeing board, can help to shape that and bring that together. Next slide, please. So I wanted to just show a bit of a practical working out of our plan in Western Wales Villages. So we're taking a 3-phased approach. So the first phase on the left-hand side is very much about bringing partners together on what we're calling a shared caseload. And we started that last month. And what that does is it picks up on some of the things that we've already heard today about the importance of people sharing their knowledge and expertise. And we have a shared caseload meeting every Wednesday morning. And what we do is we bring partners from across the community together. We have a case discussion around someone who particularly has been falling through the gaps maybe, or needing to be helped to take that more holistic approach. This is very early days. We hope that the individual will be part of those discussions, and we have sought consent, by the way, but we've been very much sort of wanting to have those discussions on those people, and that's been really successful so far. With referrals being made and people being able to unlock some of those difficulties that they were having, particularly around sitting on waiting lists and those sorts of things. So early days there, but we're seeing some really good discussions being had. And more importantly, we're collecting some really good intelligence around what's missing. So we're really finding that almost everyone that we've discussed so far is really needing some support to remain a friend, someone they can call on, someone that they don't feel like they're dropping through services. So we're really going to be starting to focus on what we can develop in our area around that. Then our phase 2 is going to start in September. And that's very much about a physical team, which we're going to be, again, around people experiencing mental illness, but thinking about how we bring a physical team together to work with those people who have more low to medium term needs. And we're really going to be thinking about how do we take those people that are being referred in by 111 and through their GP services, and how do we bring those people into the team, and how do we then really start to sort of redirect those people to the right place, right time for the right support. So rather than people going off in different directions, being on waiting lists and thinking about, falling through that gap from primary and secondary care, we're really going to be holding those people in that team and making sure that they get the right support. So it's something really practical that we're going to be doing from September. And then what we really aim to do as an ICP past September and into next year is very much thinking about how do we learn from that way of working with mental health, and how do we then start to think about how that can be rolled out to the general needs of our population in our area, and how can we think and use that in a really productive way. And all of this is really underpinned by things like what matters to me, the team around me, developing the voluntary sector, who've been a really key player working with us, really starting to make sure that we're involving people with lived experience, which we have done across all of the working with our partnerships, and also things like working with the voluntary sector. And I'll talk a little bit more about that on the next slide, please. So we knew in Western Wales Villages, for example, that we had a lot of really good things that were happening out in the community, but nobody knew about them. And we also knew that our voluntary sector wasn't as prominent as maybe it is in other areas, particularly Bristol, where I was from. So we started off doing some really big engagement events and really engaging the sector, and started to think about how we could invest some of our in-year funding with North Somerset Council to start to develop under a small grant scheme how we might want to think about developing that sector and really understanding what was out there in the community and what we could do and develop. So we've also brought together things like all of the things that were happening in communities like social prescribing, the work that was being done with the council, sort of empowering communities work, and really started to say, let's all bring that together. So we're not all doing the same things. We're not all trying to develop a community in separate areas, but we all come together with that. Again, really building links with the council as part of that and really joining up. And also our voluntary sector organisation, Voluntary Action for North Somerset Vans, has been along that journey with us, and they've very much been leading on that piece of work as part of the partnership. So that's been really positive. Thank you. So that was community mental health. I just wanted to share with you an example as well. We've heard this morning a lot about ageing well, and in Western Welland Villages we have been working as an accelerator site for our Ageing Well programme in Bristol, North Somerset and South Gloss. So I just wanted to make you aware again of another example, really good example of when you can come together as partnerships, how you can achieve change. So some of you might know, if you're providers from North Somerset, that we've set up a Ageing Well hub in 168 Medical. And what that hub is doing is it's got clinical support and it's working with 7 care homes in the area to ensure that people can stay well living in care homes, not be admitted to hospital, and that they get the right support, either whether that's clinical support or whether that's support through therapy. So that's been running since summer last year, and it's got some really, really good results so far. The amount of people being admitted into hospital is much fewer. Care homes feel that they get a really good service. They can call the hub team, they get clinical support, and you know, people are generally able to stay within the care home rather than have to move elsewhere. So that's working really well. We really want to roll that out to more than 7 care homes. So that's going to be our challenge over the next few months. Okay, next slide, please. Okay, and I think my last slide is just about how does this feel different? So like many of you in the room, I've got over 20 years of experience in social care. And, you know, we've heard this before, haven't we? We've heard that, you know, we're going to integrate, it's all going to be fine and everything will be lovely. So what's different this time? So for me, what's different this time is we've really got a will across partners to work together. I think obviously we've got the statutory responsibility coming now, which is going to focus our minds somewhat. But we've also learned a lot through COVID. And I think when I speak to partners across our partnership, that's the thing that stands out most. People don't want to go back. People have seen the benefits of working together and no one wants to go back to working in silos again. So I think there's that real movement that's been created from working during COVID. And I think that we've been really successful of thinking of and engaging with people's lived experience as part of this process. So I think that's really had a massive impact, and there's been commitment to funding there as well. And I think the other bit for me is that it's really focused on the needs of the population, and it's really focused on the individual. It's really focused on what matters to people. And I think that's very much coming through, certainly in the partnership that I'm leading in, but also I know from across Bristol, North Somerset and South Gloucestershire. And that's the end of my presentation. Thank you. Are there any questions? Yeah.
Yeah, thanks very much, Ros. I'm a bit like a broken record for lots of different things, and people will recognize me for that over time. What we have going on here, I think, is we have a marriage, but you're only marrying yourself to the social care picture. Now, there are people sitting in this room who deliver services in North Somerset, and none of those have been part and parcel of the conversations that you've been talking about. So you're busy developing, and all of those things are absolutely brilliant. So I'm hoping that when Jeff comes to speak later, he's going to be able to tell us, maybe you can too, Ros, how we're going to actually bring this marriage together in a way that you're going to have a person there as well as a picture. Because at the moment, all you have is a picture. And all of these conversations that you've been having, your developments and so on, are absolutely brilliant. But you're doing it all without social care, who deliver, I don't know what the percentage would be in North Somerset, but it's a big fat percentage of the care that's delivered to the citizens of North Somerset. So I wanted to make that comment, and maybe there are things that you can come back to me on that. But I think part of what we want this event to deliver for us today is a way of having an action plan at the end that says we're going to do these 3 or 4 things, which means that my descriptor of the marriage will no longer be accurate. So speak on, oh wise one. Tell me how you're going to do that in Western Wall and villages, please.
Okay, so I think probably I think we probably haven't gone away and done this without talking to people. I know that via, I think it comes back to a point that was made earlier, via the council, North Somerset Council, providers have been, I'm not sure, I know you're shaking your head there, Tracy, but I know that some providers, no, sure, but I think that's probably where things have happened previously. And what we really need to do going forward is thinking about how we engage you as providers as part of the partnership. And I certainly know that with David, we've had conversations about who would want to come and be our representative on our various meetings and boards in the local area. So I think there's a couple of people that maybe have been put forward, David, that to do that. So I think it's about very much being on a journey. I think the thing with integrated care partnerships are that it is a journey. So whilst we're starting quite small in some areas, I think it's that part really where you have to start somewhere and things have to try and evolve. And I think we're at the stage where we're starting somewhere, i.e. 7 care homes, and then that can particular, for example, in the care sector, that can build. And some of these things very much are test and learn. But I think what we really need to do, David, as I think you've mentioned a few times today, is we really need to make sure that that's clearer and that's that you do have that place at the table. So absolutely. Thank you.
Just to pick up on David's point, really, it's quite interesting observation that we've only got a provider voice on one ICP. So I think probably the place to start is to get providers onto all of the ICPs, so that they are involved.
Sure. And I think as well, what we're talking about in terms of an ICP, there are 2 different things, aren't there? There's things that we work together on that's different, and then there's kind of the ICP board and a meeting. So I think where we're probably thinking that we've been sort of engaging with people has been in the day-to-day work, but what we really need to do is also have that seat at the table within the board.
It doesn't look like there are any other questions around here, but I know Holly was making lots of notes, so maybe she's got some things to bring forward as well.
Yeah.
Anything in the chat? I think the hub, there was some praise for the hub there, wasn't there? That sounded like a great idea, but I think it's just what we've heard already, isn't it? There's work to be done. The providers need to be at the table, and no doubt we're about to hear more about that. So thank you very much, Ross. That was really helpful. Could I introduce Dr. Jeff Farrar, who is the chair of the Integrated Care System for Bristol, North Somerset and South Gloucestershire, and the chair designate for our Integrated Care Board. We're absolutely delighted to have you here. I understand prior to this, he had a 35-year career in the police force, which has provided lots of rich learning, I'm sure, that you brought into the NHS. And we were just talking earlier about your PhD and your areas of interest, which include equality and citizen-centred models of care, which I think really fit well into today's discussion. So may I welcome you?
I've got a few slides there, but I'm not going to use them all because I think we've gone through them. So when we come to them, I'll just move us on. Can I just start with just a little bit of background? And I know you've had some of that then in the introduction. Up until the last 3 years, I've been the chair of University Hospitals Bristol and Western. And a number of people asked me, why would you move from chairing a big acute trust with 14,000 people, great service, in surplus, doing okay? Why would you move from that into chairing the integrated care system? And my answer to that is, I'm lucky I don't have to work. I work because I choose to, and if it's not for the benefit of the citizen, then I'll pack up and go home and walk the dog, because actually we have to add value. If we don't add value, then why are we doing it? So I could have quite easily sat chairing an acute trust, but actually for me, we've got some fantastic opportunities in integrated care where we are at the moment. If we don't seize them, we should all be shot, because we have really got that chance to do something different. But, you know, I've seen it and heard it before. So that some of the things I would say to start with, on David's point, we had a conversation before Christmas, and David mentioned that you'd only been involved in South Bristol. I did say at the time, if you're not getting involved in the conversations and being invited into the other ICPs, tell me. I haven't heard anything back yet, but I will go back this afternoon. I'll speak to the chief executive, and we will have that conversation again about engagement within the ICPs. And I'll talk about the ICPs in a moment, because I think that's the real opportunity for us to make the most significant difference in integrated care. There's lots of board structures. Most of it would send you to sleep, I think, but I will, I'll go on to why I think that's important. And in the Southwest, we've got 7 integrated care systems. So Bristol, North Somerset and South Gloucester, which is the one I'll chair, is one of them, but we have got another 6. And each of those have got integrated care partnerships as well. So this is a complex model. When you saw Oona's description of what was in the ICP that she is in or involved in, that is multiplied over half a dozen times for us, and then many times over across the country. And one of the things that hasn't been discussed yet is around governance and accountability. And really important for me in chairing the ICB that we've got a real clear line of accountability. So we're going to have 6 integrated care partnerships, but they're not autonomous. You know, they have to be built within system governance, because huge amounts of money are going to be going up and down through the chain. And I can see Eli sat there who does a lot of the investigations around fraud. I'm not suggesting for one second that that's going to happen, but the governance has to be in place, and that has to you have to make sure that's very, very clear. Just before I go on to the slide, I had talked about seizing the moment. I had a conversation this week with the chief exec of SWAST, Southwest Ambulance Service, around ambulance delays. You'll have seen that on the television. The night he spoke to me, there were 17 ambulances waiting outside the BRI. Now that is criminal, isn't it? You know, that we have got a system that is not allowing people to flow through. Now, part of the problem for that, and I'll share this with you, is a number of points that I am going to be covering with the exec team, the board, and the non-exec directors that we just appointed. And these are sort of 4 or 5 really important things that I think are important for us in integrated care. The first one is system insight. People think they know what everyone else does. They haven't got a clue. So a lot of you are sat here thinking, people sat in acutes or sat in the local authority do not know what we do. And, you know, we cannot run a system where we don't understand what opportunities we've got from everybody in that system, what system demand looks like. So system insight is absolutely critical, because we've all got significant different path dependency. And if you look at local government, it was constructed in medieval times. If you look at the NHS, it's a new construct. The NHS has generally up until now been very centrally driven. Local government has to be driven by locality because we've got elected members. So we can't make decisions in the same way. So my job as the chair of the ICB has to be to lead through integrity, through leading ethically, leading in an appropriate way that brings people collectively to the right decisions. And you will detect from my accent that I've encountered a lot of this already in Wales. We legislated for it in Wales. We had the Future Generations Act. We created integrated care systems. We had integrated care boards. I used to attend 5 as a chief constable. They were all constructed with legislation in exactly the same way. Some were just a bureaucracy. Some were brilliant and made a big difference to citizens. Why? Because of inspirational leadership. And people who are prepared to say, I've got all of this accountability that I have to deliver, but I'm going to do things in the right way for our citizens, our patients, and for the public. And that's a brave decision sometimes. So I had a director of finance say to me, oh, well, okay, Jeff, now in private, let's have this conversation. I might lose my job if I don't hit the bottom line. I might lose my job if we don't hit the targets. I won't lose my job if we don't collaborate. And my answer to people now is, oh, yes, you will. Because actually there is going to be some legislation around that. And we're expecting something different. But you've heard from some of the contributors this morning that many people in senior leadership positions have actually spent most of their time in those senior positions through that period of new public management, targets, league tables. It's a way that people know. And actually, when we ask them to lead in a more public value, citizen-centered way, it becomes really difficult for people because they cling to what's got them at that greasy pole to get to the top of an organization. And it's hard to let go of it. And I think it just needs people who are inspirational in their leadership and prepared to take a risk, because all of this is not going to be written down for us. And I think that's the intention of the government on partnership boards, not to try and create a system where they're directive with us, to allow us to have some flexibility. So if you can just have the first slide. So these four things here, you've heard it mentioned so far. Those are the four aims of integrated care. So improving outcomes, population health, tackling inequalities, productivity and value for money, and social and economic development. This is about getting upstream. This is about breaking the cycle. This is not about dealing with crisis when it hits us all the time. However, we are constructed to deal with crisis. So we have to redo a whole system in a new way. So this isn't going to be quick. If we had a blank piece of paper, great. But we haven't got a blank piece of paper. But those four things there, I will start every meeting I chair talking about, which is, if we're not doing those four things, why are we here? What is the purpose of us being here if we're not doing those things? Now, people will drag down into specific detail in the boards I'm chairing, but I will bring them back into that. And I'll be saying the same to the non-exec directors as well. So the next slide, if I can. You've seen that one, so I'll whiz through it. It's just some of the data. Our shared vision. So this is quite important, but we will revisit this now as we go into the Integrated Care Board. At the moment, we have got an integrated care system. We were an STP, an ICS. I've been chairing that board. That board, and you saw the slide that Hugh went up with the partners. And you know, there's lots of people missing, but that's 35 people sat around the table. So you add in all of our partners, it will all be sat in Ashton Gate, actually probably on the field, because that's how many people we would need to have a partnership board that had everyone there. But we have to start from a position of inclusiveness, not exclusiveness. And I'm determined we're going to do that. So we have to have the right people around the table. But our aims there, you've heard about them all morning. It's talking about living longer. It's talking about taking back some control. You know, those things that we're able to do together as a collective that one single organization cannot achieve on their own. And we know that. We know that the system as it works at the moment is ineffective, it's inefficient. We wouldn't design it as we do, but we still keep on doing it. And this bit about every room, and this led to my research, and it led to how I'm actually doing this job, which is I've sat in rooms for 40 years, because I've been in public services since 1982. And everybody violently agrees in principle that we should be working as one public service. But in practice, guess what? They don't do it. Ask yourself why. And it's not because they're bad people, and it's not because they don't want to lead in that way, but they have, up until now, had to protect their own interests around it. So that's some stuff around our vision. If we move on to the next slide, because these will be, again, these will be refreshed, because 2 weeks ago, we had a new chief exec start for the Integrated Care Board, Shane Devlin. Shane was a chief exec in health and social care in Northern Ireland. So he's worked system-wide in the Northern Ireland system. I think you will see a different leadership style from Shane Devlin. That's why we've recruited him. I think that the approach he will take will be more about leading in the right way, getting people around the table, listening to people's voices, not command and control. And I speak as somebody who is well versed in command and control, and lots of people who are applauding around COVID, but actually the gold, silver and bronze groups I saw were not command and control. They were talking shops very often. They're very hierarchical, and actually an effective command and control system talks about the value at each level, not hierarchy. It talks about strategy and tactics and operations. They all have a different view. And I think we touched on it a little bit today, but if we don't enter into integrated care with a way which nobody's more important than anybody else, we just do different jobs. Some carry more risk, some carry more responsibility. But the moment anyone in the system, including the chair of the ICS, thinks they're more important than anybody else, we might as well pack up and go home. Because I know from personal experience, but I also know from the experience of many people in caring roles that they do it because they care and they want to. It's not about the money. I've got porters who used to work in the city earning 6-figure salaries, and they're now porters, and they'll tell you they much prefer their job and they're doing it because they want to do it. And I just think I've encountered in the NHS a very hierarchical structure where some people are seen as more important. Nobody is more important than anybody else. And when I see that, I can guarantee you I will challenge it. So that talks about our goals. Some of the principles, if you want to go on to the next slide for me. Some of the principles you'll see down the side, we will stick to these principles, which, you will see them spelt out, which is around individuals in the centre, subsidiarity, collaboration. I won't rehearse them because I think we've gone through them enough, and I think you probably value a bit more from asking me some Q&A rather than me running through the slide, but they are there for you. And then this next slide you might find useful, which is something around structure. Now, the Integrated Care Board, we think, because the legislation is not passed yet, but we think we will be live from the 1st of July. I'll have a shadow board running from June. Before that point, I've still got a partnership board running. The partnership board that is running on next week, one of the conversations we're having there is around the partnership board and where that sits. So when you look at that on the screen, you will see that is complex. And there's lots of people in lots of places around that. The questions I'm asking is, where's the lines of reporting so that we make sure that we know what everybody is doing? Where's the lines of accountability? And who makes what decisions? So for me as the Integrated Care Board chairman, I've got a number of different factors coming into me. I've got the partnership board, and I see the Integrated Care Board as the delivery board, not the leadership board. There's some very senior people will be on it, but it is the delivery board. The partnership board, I see as the leadership board. The conversations I hope we have this week will be that one of our local authorities will chair it. I think we're heading towards a rotation of that chair annually. We haven't decided yet who will chair it, but hopefully it'll be an elected member. Some people said, would I do it? It's not right for me to do it, I don't think. I think local authorities will have a better understanding of locality than somebody who is now in the NHS. So that partnership board, the membership of that is still up for grabs. Who is going to be on it? So that will be a conversation that the chair needs to have probably with me and others about what that partnership board looks like. But it will be responsible for setting the health and social care strategy for BNSSG. But I've also got the NHS priorities, who are putting billions of pounds in through the ICB that I will chair. So if Sajid Javid does phone me, I will have to have respond to that conversation. And one of the conversations I've had with Ed Agar, who's the health minister, and with Amanda Pritchard, who's the chief exec of the NHS, is if you keep arcing around the integrated care system into individual organisations, then the integrated care system can't work. So they have given a commitment. Now, there'll be bumps in the road here, but they have given a commitment to say that the integrated care system will have the responsibility for performance for integrated care for the whole of BNSSG. Now, that's difficult when I've got sovereign organisations who've got their own responsibilities, their own accountable officers. But if we don't get arced around, particularly by the NHS, and they come through the Integrated Care Board, we've got a better chance of success. So I've got the priorities coming in from the Partnership Board, the priorities coming in from the NHS. Those things are identified through our acute collaboration partnerships. And just, if not more important, is what's emerging from the integrated care partnerships. And I think what comes in from our 6 localities is what I said at the start, is our greatest opportunity to make a difference, because that is going to be on the ground, and that is going to be where I think people in this room will make the biggest contribution. I think you will see things change. If you sat with me on the Integrated Care Board, it would be detached from what your experience is, I guess, day to day. And I'm not sure that you'd have the biggest influence. But Partnership Board, I think maybe there's a conversation there around how care and support are engaged in that. But again, I do know lots of people want to stay involved. And then structures, I will have committees coming in from my Integrated Care Board. I'll have a non-exec director chairing those. You will see that they cut across, and here they cut across a number of different critical areas. But the one that has been touched on this morning, and it's that question around professionalising service, is workforce. Isn't it absolutely crazy that we're all fishing in the same pot? We're all competing for staff. We're offering different terms and conditions, and the public look and think, well, this is public services, isn't it? Why would there be so many different things? They're all trying to achieve the same objectives, yet they're all competing with each other around staff. It's madness. We should have a professionalized service where we start to think about how we move people, where they want to move for their own development around health and social care. We should not be protective around our own individual organizations. It's not the way to work. Now, this will be heavily resisted because people want the best in their organizations. My job is to make sure that we encourage, lever and support how we look at our workforce in a very different way. And if we do that, it will be more diverse, it will be more representative of our communities, and it will massively reduce duplication and inefficiency that we've got in our system. So this comes back to those four main objectives that I outlined at the start. Okay, and the next slide, I think was probably a couple left. So I've spelt those out, I've talked you through those. You'll have heard lots of terms today. The Partnership Board is the one that hasn't been established yet, but we're in the process. 15th of May, I think March will be a lot closer. The Integrated Care Board I'm the designate chair for that. On the 1st of July, I will be chairing it. At the moment, I anticipate we will have the 3 chief execs from the local authorities. We will have the 3 chief execs from the acutes. We'll have the GP collaborative. We will have Sirona at chief exec level. We'll have the chief exec of the Southwest Ambulance Service. We'll have Health Watch there. That will be the Integrated Care Board. That's 20 people I've mentioned already, together with the executives who are in the integrated care system, because the CCG will go, and the 5 non-exec directors that I've appointed in the last couple of weeks. So that's going to be 20 people. And I also, experience tells me that when I've got a meeting more than about 20, it's really hard to get decisions and it becomes a bit of a talking shop. So you want to hold me to account for making sure that I am listening to all of the representations around the system and making the right decisions with the money, and putting it in the right places. But, I will give a commitment here that if this was just about another NHS reorganisation, I will walk. If it's not doing something that, and I've had a guarantee on this from the Southwest Regional Director from the NHS, that she really wants things to work in a different way. I understand there will be some blockages to that, but if it's a situation where we can't operate in a different way, then that's not something I will want to be leading. So I am very optimistic. I think we've got some brilliant people in our system, some fantastic people from right the way from frontline delivery, right the way up to the people that lead our system. I'm hugely encouraged by it. I think they're crying out for us to work in a different way. They want to change, but it's been hard for them to do it. And I think up until now, we haven't had that statutory structure behind it. This is going to help us. This is going to help us. It's not going to change things radically. I think, as I said, leaders have to do that, but it is going to help us. So just finally, and I perhaps open up to questions. Back to my start on this, which was why are we going to an integrated care system? Because it is an attempt to move away from that new public management of competition to collaboration. But trust me, competition is easier than collaboration. It has been described to me as it's a bit like herding cats, and that's, it can be at times, but, I think we've got the leaders who will step up and make a difference here. So I'll be really interested to hear views or comments or questions that people may have. I've listened throughout the morning. I thought, I could have answered that one, but fire away.
So don't be shy. There's a question back there. I'm going to walk around with this microphone so that everybody can hear what's being asked. I'm going to the back first.
Hi, I'm Josh from Mabel Care Homes. It was just a quick one. Can you commit to having a Care and Support West representative on the ICP then, with all this talk about collaboration and making sure social care is heard?
So I can't commit to the partnership board because I'm not going to be chairing it, but I'm likely to be the deputy chair. And I think we should be talking about how we make sure that care and support are involved in that. And coming back to that point, which is, I actually think you'll make more of a difference in the ICPs personally. I think everybody's saying, oh, we want to be on the ICB and we want to be on the partnership board. Trust me, I've chaired the partnership board with 35 people for the last year, and you would come away very frustrated from that meeting. Oona talked about it, the ICP. Trust me, when you get up to the partnership board, it's less dynamic. So I think best use of the time would be to get you involved in the ICPs. The ICB, probably not, because if I involve Care and Support West, then who else do I involve in that setup? And it's back to my point, if I could have 50 people around the table.
Sorry, I meant the ICPs, not the ICB.
ICP, yeah, definitely. I mean, that was my conversation with David before Christmas, which was, if you're having a conversation with the chair of the ICP and you're having pushback on it, then come to me and I will ask the question as to why you're not involved in them.
Thanks for that, Jeff. I just want to add in there, though, that you do in the ICB have Sirona, you have One Care, you have got other organisations that are, they're a model of what Care and Support West is. And this isn't about Care and Support West. This is about providers, and we happen to represent providers, which is what One Care does in relation to GP practices, as you know.
Yeah.
And Sirona is probably shouldn't say this, but it's a smallish organisation on its own, and it happens to be more health related than social care related. So, but you'll take that away and you'll come back to me.
So David, why don't I ask Shane Devlin to have another conversation on that and ask people to look at what that looks like for us. I'm not aware that any of the other ICBs are involved in Care and Support West in our region. Tell me if I'm wrong.
Well, no, Care and Support West is only for the BNSSG and Bath area.
So I don't think you're involved in the ICB in BSW.
No, we're not.
But so let me have that conversation again with Shane. He'll have a conversation with his counterpart in BSW. I can't give any guarantees on it, but I will go back and have the conversation again.
It'd be great to continue the conversation. More questions from here. Oh, wasn't you? It was over here somewhere.
Your initial point of the 17 ambulances outside, actually, the representatives here determine that back door. So I kind of feel that not having somebody that can represent the back door, we very much concentrate on the front door, and that's where the ambulances are, but the shortage of services, the commission services of the back door.
Well, I completely agree. So an acute trust has generally been incentivized for many years to think front door and back door, not what comes in the front door, what goes out the back door. It has been, the targets, if you look at them, are generally about what goes into what's in the organization. It's a flawed system. The other thing that we've done in all our organizations is we've done lean processing, or we've done system thinking, or whatever term you might use, but we've done it within our own organizations, and we've very rarely done that across the whole of the system. So if you look at the person's journey from, first of all, why did they phone the ambulance? Did they need to? Right the way through to why can't, when they go into a bed in BRI, or even when they go into casualty into BRI, why can't they get them into a bed in one of the elsewhere in the trust? Or then, why can't they be discharged if they've been in a bed for 3 or 4 months? You know, I don't think we've ever really effectively leaned the whole of the system to look at the impact of every individual part. We talked about it and we established a goal group, but it doesn't do that, you know, that really hard yards of system thinking. So I completely agree with you, you know, that you've got to look at the system as a whole, or otherwise you can't mend it. You just create knots in the system where we then start blaming people. So I get, well, it's the local authority's fault, or it's the acute's fault, or it's, you know, one of the other things that is a clear point that I'll make with the board is the ability to redirect attention. I hear it all the time where people say it's out there, and they never say it's in here. And actually our ability to say, yes, it's us as well. People really just don't like to do that. They want to blame everyone else in the system rather than themselves. And so I do agree. I think, you know, what comes in the front door, what goes out the back door, why doesn't it, is crucial to how we're going to change our services. And that's where Shane Devlin is today, having that conversation about ambulance service provision. And I will have the same conversation with the chairs of the partners in the existing partnership tomorrow evening.
I'm from Learning Disability Services, so my concern is that we're a small population, and will we still have such a voice, or will we still remain that Cinderella service within the ICPs, especially around elderly care, mental health, all of those things?
So are you involved with the ICPs at all? Have you been involved in the locality?
No, not as yet.
So you know, I think that engagement around learning disability within the ICPs is critical. So Ros is here, might be worth a chat with her afterwards. You know, it's early days for us yet on it, because, you know, we're not statutory until July, but back to my point at the start, we want to be inclusive, not exclusive. So I would prefer to have more people around the table than less, you know, particularly with the ICPs, because I think you'll make it work. And then I think you'll need to decide for yourself, you know, what value are you adding at the ICP? And you might find your time is not well spent there, or it is. But, you know, we absolutely should be invited there.
Just for clarity, so that everybody understands, we are in discussion with Ros, and actually your boss may well be sitting on that ICP. So, so I wanted to make the point that, you know, I'm not only here to criticize, although I will, but I am also here to clarify where we've made progress and where we haven't. And that's one of the places where we are in making progress. Richard.
I was only going to follow up on my first question. Thank you very much, Jeff. That was very clear. And I think we're very pleased to see that you see the opportunity that exists here. And if we don't get it, if we don't take advantage of that, I don't think we should be shot, but it's not a bad analogy to use, but thank you. And I apologise to Hugh. I wasn't jumping on you, anyone. I was just suggesting that perhaps at some point we need to have the open conversation about the ICPs. We are struggling to get onto those. And so I'll be interested to follow up with you in a couple of months if it's not working. And the efforts that David's putting in on the behalf of all the providers, that we are keen to get involved in that.
So that offer is there for me. You know, if you ask me the question, I will ask it back into the system. So, you know, if you feel your voice is being blocked or not being heard, or you can't break through, one of the values of the chair is, I'm not going to give you the answer you want, but I will absolutely be able to ask the question back in the system, which is, tell me why we're not. So I'll be able to reflect it back in. So yeah, really important.
Thank you.
There's a question on the chat that it would be useful, I think, just to read out. I'm a little bit confused about the structure Jeff explained. From previous information, it seemed that the ICB were the lead of the entire ICS, but is it the partnership that would technically be leading the entire ICS? There are lots of initials here, aren't there?
Yeah, there are.
I can.
So all right, okay, let me explain it again. If you put the integrated care board in the middle, that will be me chairing it with the four exec members from the ICB who were in the CCG, the non-exec directors, our board structure. We will be a statutory board. So the ICB will be a statutory board with statutory functions. I will then have to I've described it as sort of acting like a funnel, where what comes in at the top is our local partnership board, so our BNSSG partnership board, which is not on a statutory footing, but what comes in from them as the health and social care strategy comes into me to deliver. What comes in from the NHS with priorities, what the acute collaboration is identifying, what's coming in from the ICPs, all comes into that funnel. And then I, as the chair of that board, have to make sense of that. Now, there's billions of pounds that are going to be coming in through there. So I need to make sure that we are apportioning finances to the right places to do the right things. Now, there'll be a balancing act on that, because I might get NHS national priorities, which I wouldn't say conflict, but they might not put the right level of emphasis that we've done in our local strategy. You know, I think my job as the chair and the chief exec's job is to push back when we need to. You know, we're going to have to push back into the system, not just be led by the nose. And as long as we can do that effectively, we will have a useful system. I think wherever we make decisions, we should be able to give an accompanying rationale. So I should never be making a decision at the board where I can't explain exactly why we have done what we've done. Because, you know, if we don't do that, then it's an ineffective system. So no, the ICB is the statutory board, but there is lots of things. I wouldn't put them in a hierarchical model, but will actually influence what the ICB does.
Thank you. There's a lovely little comment here. Don't we just need proper social care representation on an integrated partnership board, regardless of how dreary and frustrating it might be?
Well,
I'm not saying I said that.
Well, yeah. Hopefully, it's not too dreary and frustrating. But you know, we have to think whole system, David, because at the moment you isolate an individual part of the system, you are not thinking whole system. And it's back to my point. Just because you're running an organisation of 14 or 15,000 people and have a £750 million budget, doesn't mean you're more important than a GP surgery. It doesn't. We just do different functions.
Thanks. Are there any other questions in the room? Oh yes, there's another microphone.
Hi, Dave Anglin from Manor Community. I'm also the chair of Care and Sport West. I've just got alluded to your point just now. I think today I was quite positive coming in. I'll go away very positive from I think the presentation has been really, really good from everybody. And particularly yours as well, in terms of what you've said in terms of leadership and equality, etc., between all partners. The only thing I'm conscious of, and I've had a few discussions in the break with people, is that I think you can get a lot of goodwill and you can change the service and make it better for people in the local area. However, can it be that transformational, which it needs to be, without the national change in terms of more funding, etc.? I just wanted to. I know it's not necessarily your role, but I do see that the huge benefits it can be for local area with the changes you're putting forward. But generally, I think nationally there has to be a massive change. Well, do you believe that, or do you think you can actually do it on a local level based on what you've already got?
I think we can have a good stab at it. I really do, and I think we shouldn't be creating a postcode lottery. So we shouldn't have one ICP that's marvellous and one that is really suffering. And we do need to recognise that what's in the ICPs, as I said, can't be completely autonomous, because someone like AWP has to provide a mental health service. So it can't be completely different in different places. So there has to be some sense of system. I came from an organisation where I took nearly 60 million pounds out of the budget in 2 years. I went from 120 buildings down to 17. I halved the workforce. We didn't become less effective, truth be known, through austerity. Local government have lost 60p in a pound. In the NHS, we haven't. Now, that is not saying the NHS doesn't need the money, because demand has massively increased. Public expectation increases all the time about the services they get when you've got an illness. So I've got every sympathy with all my colleagues in the NHS, but the efficiency savings that we've done in other areas of public services, we have not done in the NHS to the same degree. That is the truth. Now, there's lots of reasons why, and there's lots of politics in that, and there's lots of some very strong views on it. But I don't think it is just about more money coming in. I actually think it's about us working differently, and I think we should be able to do that. But we need to recognise that we don't all start from the same place.
Just just a question here. On what basis do you think that social care, oh, it just moved. Social care moved. On what basis do you think social care is going to be fixed without significant additional funding? I mean, you weren't making that point, but
no, I mean,
but
it's crippled, isn't it? I mean, I have to say, that the funding that's going into social care has to increase, doesn't it? And we keep having that argument. So the chairs system now, there's 42 of us across the country, and there's some really, significant. Patricia Hewitt's a chair of an ICS. I've got Liam Donaldson, who used to be the chief medical officer. So we're a really strong group of people, and we've got quite a powerful voice. So we meet with the health minister. We're now trying to get a meeting with the social care minister. I hope that's going to be on the diary, so we can make the points to her about we cannot effectively run health and social care if social care is not being funded. Everybody is saying that. Social care cannot continue in the way it is, and I think Hugh made the point earlier. If you look at the amount of budget that goes from local authorities now into social care, it's the majority of the budget. Yet still, it's not enough. So I completely agree that we always need more money in there. But I do think we can do things differently in our own system.
thank you for all of that. I've just added you, by the way, to my speaker list for the annual conference, which is on June the 7th, which is entitled.
I don't know yet.
Which is entitled "Fixing (brackets local close brackets) social care for 2030." So I think it would be really, if you could, that'd be great.
Yeah, if I'm available, I'll do it, David. Of course I will.
Thank you. Are there any other questions in the room? Otherwise, I'll hand back to Holly, and she's got some points she wants to make as well, I think.
Okay.
Thank you very much, Jeff. Thank you.
I don't think I've got too much to add, actually. Everybody may be glad to know, but thank you, Jeff. That was quite reassuring, I think. I'm sitting here with a health hat, so I'm aware that I'm in the minority probably in the room and virtually. But I guess the big challenge is still going to be about the power balance between health and care, isn't it? We don't like to talk about it because we're all colleagues together and it's all about collaborating. But I guess that would be my plea to you, would be firstly to address the request for providers to have a seat. And you could argue it all sorts of ways why they shouldn't, but there definitely are other organisations that speak for health, the community and for general practice. And I think that social care should have a space at the table. So if you could facilitate that, that would be my magic wand moment. The other bit was around, that you mentioned, was around training, and that's kind of dear to my heart because my background's in education. And back to the point raised earlier that Wendy had raised, in terms of that career pathway, that why is it health and care? We're sort of doing the same kind of thing, but I mean, that's going to be smashing up all sorts of institutions and so on and so on. But I think that could be an aspiration, and it could begin with students, because you tend to stay where you learn. So if you train where if junior doctors can go and work in social care as well as in hospitals, if GP trainees can do that, and if colleagues from social care can come and do placements in health, I think that's going to change it. It won't happen straight away though, will it? So thank you for your time. There absolutely is. No, you're absolutely right. And the doctors often have the voice in the room, and they shouldn't do. So I'll end on that note, if I may.
Thank you, Doctor. I just thought, though, to finish off, sorry to interrupt you there, Holly. Just thought to finish off, do people want to have a 5-minute chat around their tables and see if there's anything else that comes up as discussion between you? And then we can ask some more questions, either of the three speakers in the room, or of course we had 3 other speakers who may or may not still be on there. But just a 5-minute chat around the room, see if there's anything else you want to highlight for Jeff and others to take away. That'd be great. Okay, if we could draw that to a close, please. Good to see the chatting around the tables. That's lovely. Are there any other questions that have emerged as a result of the chat around the tables, or any comments people want to make? Or yeah, at the back, we'll come to you with a microphone.
Hello, I'm Sam from Able Care Homes. Thank you to everybody today. I feel quite hopeful now about us getting more involvement in the ICPs. But I would just like to say that I thought, Ros, your presentation was really helpful explanation of what's happening on the ground at the moment. But there were some things I picked up from that social care providers aren't included at all. And you talk about working with the voluntary sector and getting good insights into what services they can provide. Well, nobody's asking about what social care can provide and how we can be included. And I did pick up particularly with what you were saying about the hub to support certain care homes. But you very much said that this is going to be happening to the care homes, not with the care homes. And I think to me, I just picked up on that it's like, well, we're not included in social care at the moment. And I hope today can help start to change some of that.
Do you want to respond to that, Ros?
Yeah, thanks, Pam. I think absolutely there has been a lot of work with the care homes that were involved. So I don't really want it, I really do mean it to be done too. It is very much with. So I think it'll be really positive when you're part of the integrated care partnership to have that representation to get into that more in a more formal basis, because I think that is happening on an informal basis. But yeah, absolutely. Thanks.
And I think, Hugh, your colleague Gerald and Hayley down in North Somerset have done quite a lot of work around that, working with Ros and so on. There might be some learning there, I guess, for Bristol and South Gloss that maybe we can pinch. Maybe you could ask Gerald and Hayley to be sharing some of that. Well, sorry, not pinch. I mean, replicate.
This is the beginning of the question, but yeah, always.
Okay. Another question back there.
Hi there, I'm Steve Ray, Delivery Director for South Bristol ICP. Fantastic, of course, to hear from Oona, who I can see on the screen today. You've got 2 out of 6 ICPs represented in person here in the room today. Obviously, hearing many comments about actually, in many of the ICPs, we haven't got to a place of having care providers around the table. I just want to kind of give my voice that there is the absolute commitment that we want to do that, because we're about communities. And we've also talked about geographies and scale. We've talked about, I think it was mentioned that actually we can't do things, we're not going to be kind of ring fenced around our ICP boundaries, that we do things in South Bristol and it's absolutely different in City and East or in Woodspring. We're going to be doing some things at that system level. Some things, we know that we've got many, many different communities within South Bristol, whether they're communities that define themselves by roads, by favour communities, by social groups. And actually the place-based size and scale of 170,000 people in South Bristol is okay, an effective scale, I think, to be effective and work together as providers across the patch. But actually we recognise what we're going to be doing, we're only going to be truly really effective if we get down within the communities and work with them to understand their needs and how we can better support them living their lives. But I particularly wanted to just pick up on that first point, saying, please don't take away the fact that, ICPs don't want to include care providers. We're on a journey. It's still quite early on in the journey. You've heard from Oona, you'll hear from Ros and myself about how valued I think we recognise that representation needs to be. So please do take that positive message.
Thank you. That's good to hear. Another question towards the front here. Thanks very much. There's another question over there, but I just wanted to check. Oona, do you want to come back in with any of that?
I couldn't hear the question. I could hear Steve's. I couldn't hear the other one. Was there?
Yeah, I was just wondering, Oona, whether you wanted to say a bit about, if you like, how you've been welcomed at the Bristol South ICP and your feel for that.
Yeah, I would absolutely agree with Steve. I think the door is open, and there hasn't been any resistance at all. It's almost like all hands on deck. Whoever can make that contribution is prepared to put the time in and do that thinking. And I did actually want to reflect. I think it was Chris actually at the beginning when you talked about the headspace, or was it Hugh? The headspace that will be needed. And I think that's one of the critical points, is how do we allow the space to have the sort of conversations that we need to have? And I will reflect back on, over the last few months, I've been involved in a number of conversations about winter pressures with various bits of the NHS and CCG. There are a lot of people, and I think, Jeff's comment about austerity and what he's had to do in other organisations. There are a lot of people talking about this. There's a lot of people thinking about things that are very immediate today. And I wonder if there's, it's my ideal world, being able to direct some of that, oh my God, we've got a crisis today in the ambulances, whatever, to how can we sort this out? How we can have some longer term thinking, some longer term strategy. Those people are there doing the thinking. I would just love it if we could direct them towards some of that future models. I'm often the only provider on some of those calls, and I can't help but thinking we could use it in a better way.
Thanks, Oona. Hugh, you have. Oh, sorry.
I was just going to respond to Oona's point and completely agree, David. I think one of the messages to the 5 non-exec directors who will be chairing the committees for the ICB is they have to occupy that space of strategy and transformation, not looking down into individual organisations all the time. And the 5 non-exec directors we've picked, I think, will occupy that space, and that's why we've picked them. So Oona's absolutely right. And then how do we get people to make the headspace and get there? Well, there's going to be a greater incentive, because a lot of the finances that would have come to individual organisations are going to be funneled through the Integrated Care Board. So that will sharpen people's thinking when they haven't got the same money coming to them if they don't engage. And then there is a duty under the Act to engage as well. So, but it's back to my point I made earlier, it will be about the type of leaders we've got. And I think that's my job and Shane Devlin to make sure that we are engaging in that way. But the conversations I've had with him are very much like-minded around that and occupying that space.
I think it's good to hear that DOSH equals for results need to come to get the DOSH. That's a really good one. Hugh.
Oh, does this work? Oh, yeah.
It does, yeah.
I was just going to initially going to very briefly respond to your point, which was about should have been involved from the outset and all of that. And I'm going to say that awful managerial phrase, which is we are where we are. I certainly made heavy play in my presentation of the fact that I've been working on stuff like this for 20 years. You've been working on it for 40 years. And you've got to think about how it was presented to us over those 20 years. And it's been extremely top down and it's been extremely prescriptive. And I think for the first time in my working life of doing this kind of thing, it actually feels that we're in a situation now where it is not necessarily going to be following a load of diktats from NHS England or from the Department of Health and Social Care, that it's kind of up to us how we do it. So that's the we are where we are bit, because we're in a position where we are now opening a door that perhaps we wouldn't have been able to open so effectively 5 years ago, 10 years ago. And so there's never been a better time than right now, said the Red Hot Chili Peppers, I think. But I think there's never been a better time. This is the time it's happening, and this is where we are. And I think, I'm really, from all the speakers today, and it's the first time, I've heard these messages from these folk, but everybody's saying the same thing. The door's open, come and join in. This is what we want to do.
Thank you.
So David, I would agree with what Hugh was saying. However, perception equals reality. And if you feel that you've been excluded, then it feels like lip service, and it's not. The door is open. We want to make a difference. I'm trying to chair this thing, and I'm determined we're inclusive, not exclusive. So the opportunity is there, but I have got some sympathy, and I think it's born out of, we think we know how the system works, or people do, and they don't, because they haven't immersed themselves in it. We're having the conversation at this table. If people spent a morning with you, not watching what you're doing, but rolling their sleeves up and doing what you're doing, they'd have a very different view about the worth of your involvement, wouldn't they? I would guess. And we just don't do enough of that as well. And we need to train people in a different way. I'm going to join Hugh's comedy bit and say that your presentation today has been very arresting. But so let me stop there. Can I just say to Chris, I see you there on the screen. Is there anything it would be useful from that kind of national perspective for you to be adding here at the end?
I think all that's in my mind, David, is that there's principles and then there's practice, and the two aren't always aligned. And I think I agree with Hugh about the point about, you know, there's never been a legal framework has been more kind of conducive to working in partnership, assuming that the Health and Care Bill goes through Parliament. Pandemic where people have been working together more closely than ever before, and that gives us something to build on. These sounds good in terms of, you know, giving local leaders the space and the discretion to make the decisions that they need to make locally. So in principle, you know, this feels like a good time to be doing this work, and I think we should all be hopeful. What we need to keep an eye on, and it is great to hear, you know, Jeff talking about how he'll be using his position as chair of the ICB to keep an eye on some of these things, is whether those principles get converted into practice, because there are always kind of gravitational pulls that can lead the system to recreate the status quo rather than to make the change that we all want to make happen.
Thank you, Chris. I'm just going to add a comment from the bottom here from one of the virtual audience. And maybe this is something we can do in partnership with you, Jeff, and the ICPs and the ICBs. So why don't we turn it on its head, and rather than being top down, base our learning and development of integrated health and care systems grounded in what is and what needs to be happening for frontline services. So that, I think, fits with what people have been saying, really. Are there any final points anybody would like to make? Holly?
If I may, yeah, just going to add in terms of experience during the pandemic, I was part of the team that developed a workforce to go across the system. And what I constantly heard was, it's too difficult in primary care, it's too difficult in social care. But it was the first time that I have ever seen everyone coming together and genuinely trying to make it work. And there were a lot of problems. Jeff's nodding, but I just don't want that to happen here. I think it's got to be translated into action, and we've got to listen to what people say who are doing the jobs on the ground. Thank you. Thank you. I think I'm going to close off now, but I just wanted to thank roundly and soundly all our speakers. So Chris from King's Fund, thank you so much for being with us, even if it was remote. We can see you there. Hugh, thank you for your input as well. Oona, get well soon. We hope you will. Thumbs up there. And Deborah, I'm not sure whether Deborah's still on the system, but thanks to Deborah as well. Ros, you're here, and of course, Jeff. We hope that we shall see many of you on June the 7th. You always got to plug in. On June the 7th, again at Ashton Gate for the annual conference for Care and Support West, which, as I said earlier, will have that title of fixing. We're going to fix social care during the day, that day, for 2030. And it will be good if you come along and help us do that. So thank you for your time, everybody. Travel safely when you go home, and it's been great seeing you all. Thank you.